Now we will begin our first clinical module featuring our experts from the Baptist Health Miami Neuroscience Institute. We use acronyms a lot, M&I. Recognized for leadership in complex neurosurgery, advanced stroke care, spine surgery, and innovative treatments for brain and movement disorders. It is my pleasure to introduce our moderator, Dr. Michael McDermott. He is the Chief Medical Executive and the Irma and Coleman Bass Endowed Chair in Clinical Neuroscience at Baptist Health Miami Neuroscience Institute. Dr. McDermott is one of the world's most respected neurosurgeons, known globally for his expertise in meningioma surgery, skull-based tumors, and advanced neurosurgical techniques. This module highlights advancements in spinal deformity surgery, acute stroke care, movement disorders, functional neurosurgery, and minimally invasive spine surgery. Today's sessions will feature presentations by Dr. Raul Vazquez-Castellanos, Director of the Complex Spine Surgery, Dr. Felipe de los Ríos La Rosa, Director of the Stroke Care and Irma Bass Endowed Chair in Stroke Neurology, Dr. Diego Torres-Russotto, Chair of the Neurology and the Distinguished Endowed Chair in Neurology, and Dr. Michael McDermott, Chief Medical Executive and the Irma and Coleman Bass Endowed Chair in Clinical Science, Dr. Aviva Bosch, Deputy Director, Director of Epilepsy Surgery, Co-Director of Functional Neurosurgery, and the Acernia Endowed Chair in Surgical Treatment and Adult Epilepsy and Movement Disorders, Dr. Guilherme Dabus, Co-Director of Interventional Neuroradiology and the Director of Interventional Neuroradiology Fellowship Training Program, Dr. Michael Gomez, Director of Minimally Invasive Spine Surgery, and closing the module, Dr. Michael McDermott. So we are honored to have such a distinguished group with us, and with that, Dr. McDermott, the floor is yours.
Morning, everybody. Thank you for attending. First, we'll have Raul Vazquez, who is my surgeon. Did a lumbar discectomy, 52 minutes through a 22 millimeter tube. But today he's going to talk about advanced spinal deformity correction surgery. Raul.
Good morning. Thank you for having me. This is, I think this is like the second or third year I participate in this, and it's good to reconnect with some of the people from the Dominican Republic. I was there recently giving a talk really similar to this topic, but today I want to give a very brief overview of what is new in adult deformity surgery, or what we call scoliosis surgery in the common language. Let's see. There you go. All right. So let me go back here. So the purpose of this talk, we're going to, in 20 minutes, try not to overwhelm you with the information, but I'm going to briefly talk about what we talk about adult spinal deformity, what that means, what the major cause of these prevalent surgeries. And I'm going to briefly talk about what is new in terms of technology, the new advancement in personalized treatment, and how we are trying to incorporate less invasive approaches and improve recovery. Why is this important and prevalent? Is because back pain is very common. We're all going to have back pain at some point. At least 70% of the people in this room in a lifetime is one of the main reasons of disability, and missed work days, and it's a very expensive pathology and problem in the community. Why is happening more often? Because we have a rapidly increasing aging population that is still pretty active, and they are surviving longer years. The main driver of this disability is the classic sagittal balance of positive shopping cart sign. You know, your loss of alignment in the spine. What is adult spinal deformity? Briefly, It's a complex disorder that involves imbalance. It's when our spine go out of balance. Is increasing in an aging population, and it causes significant disability, pain, and decrease in the quality of life. These are the key alignment principles when we talk about spinal deformity. We look at the natural curves of the spine, right? Thoracic kyphosis, lumbar lordosis, and these alignment to our pelvis, how we walk in a straight posture, or if we can preserve that, what we call the global tilt. So how we go from the picture on your right to the left, from a simple surgery 10, 15 years ago to a major reconstruction later on in life, unfortunately when we are in our 70s or 80s. And that's what we call post-laminectomy syndrome. It's a group of disorders that involve anything from instability, adjacent level disease, recurring stenosis, failure of the instrumentation, non-union, pseudoarthrosis as our bone age, and we develop osteopenia, osteoporosis, and all these get complicated. One of the main things that had made this possible since I started training in the early 2000s, is the navigation tools. We are in the third iteration of spinal neuronavigation. One of the main advances that had made possible making this surgery even safer for both the patient, the surgeon, the staff, because it's less radiation. But now at Baptist, it's a gold standard. We all practice spinal instrumentation with neuronavigation. We're in the third iteration of the O-arm, and this is an example. Make a safer placement of the screws, and this is a CT-based image that we use in the surgery. Another of the main things that had a concept that have improved the planning and make this surgery safer, and we routinely do this, is a 3D printing of the spine. We use CT-guided computer reconstructions of patients that have severe deformity, like the one you see here on the right. And we can guide the osteotomies, we can plan the surgery. As you can imagine, this would reduce OR time. It would, you can predict the amount of screws that you're gonna need to stabilize the spine and reconstruct the deformity, fix the deformity. These are the concept of like patient-specific cages that we are now more commonly and routinely using to plan these kind of surgeries. Artificial intelligence, I have to talk about this because I had a wake-up moment maybe like 2-3 years ago when 2 years ago actually, when I'm preparing for a presentation, and a medical student looked at me and that is in the lounge, and I'm working on a presentation, putting the slide together, and he says like, what are you doing? And it's like, well, I'm doing my PodMed search. I'm preparing this presentation. I know a lot of these papers. I read. Every Sunday I read the journals, and you stay up to date in the literature, and but you know exactly what to look. But he said, no. I mean, there's a program that actually makes your presentation and do your research. It's OpenAI. We have ChatGPT. And it's like, oh, really? I use ChatGPT. I know, but why are you using ChatGPT for presentation? There's another platform for that. So it makes artificial intelligence have take us to another level of surgical planning, anywhere from OpenAI to a presentation tune-up to even a surgical planning, predicting outcomes. And more importantly, I think, is patient selection, because at the end of the day, we have to evaluate our host, our patient, and that's where it's one of the major advances that we had in the past, like I would say 2-3 years in what we call adult spinal deformity surgery. It's not only personalizing the care based on data that we obtain through supercomputer and like very intelligent platforms, but also predicting outcomes, and that we can translate on how aggressive we can be in the correction of the scoliosis without hurting the patient, and to a certain extent to make this surgery worth it. So this is a very non-review, recent that kind of like summarize how artificial intelligence, we use it every day, including in the OR. Now, the navigation tools that we use, like this O-arm, have very good AI tools to plan the screws, how long the screws were you going to use, if we need to cement based on the quality of the bone. So we can predict who's going to fail the surgery and who's going to do better, and how we can optimize that outcome. So this is it is on the works. You know, one of the main challenges that we have when we come to artificial intelligence is the data sourcing. For years and still, you know, the privacy rules and the lack of participation on the data flow, different from Google or the social media like Facebook or all the social medias that we use daily. The data when it comes to healthcare is very limited, because we have come to the point that even papers are generated by AI. So if we don't have a good data, that's the result is going to be a good algorithm calculation by the AI robot. So it's one of these things that is still a challenge, and we're working on it, and I think they're working very actively and helping with that. Augmented reality and robotics. I mean, this is a question that we get at least, I do get at least once a week. Are you going to use robot on my surgery? And you have to educate the patient, right? Like, the robotic technology is still in a lot of development. As a personal consultant for one of the companies that help us, we're trying to build a more efficient, integrated AI robot. But unfortunately, right now, the applications are limited to bigger surgeries or the ability of using what we have as robot now is like an assisted arm that help us place the screws in a more precise way, especially when we have severe cases of kyphoid scoliosis. But as you can imagine, the patient selection, the trial and error, and still the workflow has to be optimized and developed. But it's something that we are on the works and trying to incorporate more and more in our cases. Augmented reality has helped a lot, especially in reducing that fluoroscopy time. And like you can see in this picture, is help on that view overlays of the spine while the surgeon is operating. In one of the main advances nowadays on deformity cases is the personalized algorithm to customize the surgery and the care to the specific patient based on complication reduction strategies. This is challenging because we relied on multiple risk assessment tools that can go anywhere from your quote unquote, like we call clinical eye, right? Because you can have a patient on a medical chart that looks great, you know, but then when you interview the patient physically, he gives you some concern. So that's when we go and go into multiple risk assessment tools that helps us reduce the amount of complications in these big surgeries. Some of these surgeries now, even in the more complex cases, we do it between 2 surgeons in order to reduce the amount of time, but they go anywhere from 5 to 6 to 7, 8 hours. We try not to do this more than 7.5, 8 hours, because we know that after 7, the risk of complications start creeping up in terms of anesthesia and pulmonary issues. That would lead us also to the patient selection, and we have developed very, very intricate protocols of what we call enhanced recovery pathways. So it's not uncommon from the moment, even before surgery, that the anesthesiologist is talking directly with the entire team, the surgeon. They're already planning on the post-op pain management care, post-op mobilization, et cetera, to prevent complication. So here at Baptist, definitely we relied a lot of a very strict, but at the same time, personalized protocols, because we can adjust based on different patients. So the risk assessment tools that we use and I do consider that this is one of the major advances in adult spinal deformity surgery, because before the scoliosis surgeon will do the surgery almost without consulting anyone, and besides the medical clearance and cardiology clearances. And now it is on the surgeon to utilize these tools, like the frailty scores that is widely implemented, I think, for almost all our cases, including cranial cases. We use frailty scores because that help us reduce the amount of complication, and we can understand how aggressive we can be with a surgery on a patient. Some of the most commonly used by anesthesia is the ASA. We have the CCI, the Charlson Comorbidities Index. We have predictive models. These are usually some of them AI generated that can predict complication. You enter the numbers, you enter age, different comorbidities, and can predict you the risk of different complications. And like every surgery, this is a combination of reality, outcomes, and patient's expectation. I think a well-informed patient that knows what is about to undergo, like a deformity correction surgery, if they understand their risk, their benefits, then they can make a better decision, and they will be or not satisfied with the outcome. This is a paper, that describes the use of older concepts that, one of the questions remain is with this aging population, like why is, that's the main risk, the main questions that we have every day for everything that we do in medicine. Why is that I did exactly the same surgery on this patient and this patient, the same age, and one does well and the other one didn't recover that well, or that person took 6 weeks to recover and the other person took like 6 months to recover. And now we're trying to understand the relationship of aging with our genetic components, like telomere length. What is the real biological age of the patient? And that is something that we're incorporating in all these risk assessment tools. And we still have a lot of questions to answer. And for me, and for a lot of, when I go to this meeting, for a lot of these deformity surgeons, scoliosis surgeons, they are more and more relying on this. Why is that a patient that I see that is 80 and it looks great, and then, and you have a patient that is 80 and looks like 90 versus. So that's with the concept of biological age that we're incorporating more and more in making this decision making and deciding who's going to have that surgery, And also the concept of biological resilience. When we have an injury, it takes longer an older person to recover than a younger person, and how we can optimize that prior to surgery so that they can have a faster recovery in terms of, so that guide us in terms of how aggressive we can be with the surgery. These are some examples of cases that we do. At least we perform at least 1 or 2 of these surgeries a week. As you can imagine, it's very taxing for the whole staff, for the surgeon. So we would be doing more, but it is a very strict patient selection. We go from a very flat back deformity to one with a lordosis, a correction, and an adequate alignment, and someone that has prior minimal invasive surgery with a severe deformity and then correction of the scoliosis. There's some of the example cases. So where are our future directions? We know more and more we are personalizing the spine surgery treatment. We are integrating the robotics with artificial intelligence and augmented reality, and this being almost the standard. We do this practice every day. And we are customizing implants. Like now it's not a general rule for everyone, so we try to make implants, cages specific for every patient, depending on their bone quality and the degree of deformity. And we are across the board implementing risk reduction protocols that can predict outcomes and improve the satisfaction on these patients. So this is pretty much it. Thank you.
Thank you. Okay, so thank you, Raul. Next, we'll have Dr. Felipe de los Ríos, who's the director of the stroke program, and he's going to speak about advances in clinical innovation.
Morning, buenos días. I'm Dr. Felipe de los Ríos. I'm a vascular neurologist, and I will be going over innovations and some updates on acute stroke care. As far as disclosures go, I'll just be talking a little bit about some off-label use of alteplase and tenecteplase, which are the 2 main thrombolytics being used for acute ischemic stroke. And as you know, stroke is very common, so 1 in 6 people are expected to have a stroke at some point in their life. So most of us know someone or have been touched in some way by cerebrovascular disease and stroke in particular. So it's a leading cause of death, but most importantly, it's a leading cause of disability. And there's a lot of things that we can do to both prevent and treat stroke. So about 80% of stroke is preventable, and there's been a lot of innovations and new things that we can do for both primary and secondary prevention of stroke. We now have, of course, thrombolytics. Alteplase was approved in 1995, and we're still learning best ways to use that medication, as you'll hear a little bit more on the talk today. And there's newer thrombolytics and combination of antithrombotics that are being studied and discovered. It's a very fast-paced field for sure, but the number needed to treat for thrombolytics early on after an acute ischemic stroke is 3.1. So that's that's a fantastic number. Having to treat only 3 people to significantly change and improve the outcome of patients with stroke. We also have thrombectomy, which is the endovascular treatment of acute ischemic stroke, and Dr. DeBoos will be going over some of that information with all of you later today, this morning. The number needed to treat for that is about 2.6. And the good news is that both of these therapies complement each other. So thrombolytics works best, as you would imagine, for smaller, more distal clots, and thrombectomy works best for bigger, larger clots. So they tend to complement each other very well. And how to best use each of these therapies is still really on the works, and it's expanded every year. So I'll go over some of those changes as well. And we also have newer treatments, and as far as who would qualify for management of, for example, asymptomatic carotid stenosis, And really, stroke center certification is going to be a key part of acute stroke care. So it's good for all of you to reflect on each of your individual countries and cities. I'm originally from Lima, Peru, so this is an area where truly there's a lot of things we can do. It's kind of low-hanging fruit because there can be centers that can have specific tools, physicians, technology, and resources to treat some of these stroke cases or complex stroke cases. But if it is not within an organized system of care, the assistance that center can provide to the community is really limited, versus if it is an organized system where people know where to go for a very time-sensitive condition like stroke. So I'll just go over some of the main highlights and innovations that have happened with stroke care over the last year or so. And one of the big ones is tenecteplase. Tenecteplase is a thrombolytic that has some advantages compared to alteplase. And it has been studied for stroke for several years now, but this year received FDA approval for the management of acute ischemic stroke. We've been using it here for several years already. We're one of the early adopters, but some of the benefits of tenecteplase are there. It has higher fibrin specificity. It can have better recanalization rates, specifically for larger clots. And that's important in situations or in scenarios where the patients do not have readily accessible to an endovascular neurosurgeon. It has a longer half-life, and this is one of the main advantages. So alteplase really has about 5 minutes, less than 5 minutes. And with tenecteplase, the half-life is 90 to 130 minutes. So what that means is that we don't have to do infusions, right? So with alteplase, we would start the patient on the thrombolytic, and then the infusion would run for about an hour, and that created a lot of logistical issues for those of us who see systems of stroke care, because then the patient had to be transported with a pump, there would be medication in the tubing, the ambulance, how does the pump return to the sending hospital, lots of things. Infusions being stopped halfway because of access issues. So tenecteplase has really changed a lot of that, because now it's just a single bolus, the patient can be transferred, there's no pumps, the IV gets released so the patient can receive other medications. So that has been a big game changer for us in acute stroke treatment. Plus, it has a lower cost. So it's a win really all around. Now, there's new and additional studies as far as how far off from when the patient has symptoms can we treat with thrombolytics. So the FDA approval is for 3 hours, guidelines say 4.5, but now we have 6 studies and a meta-analysis, a couple of meta-analyses that support use of thrombolytics up to 24 hours from when the patient was last known well. So this is really revolutionary for a lot of countries, specifically if you don't have access to thrombectomy. Many of these studies, though, did use advanced perfusion imaging for patient selection. So that could be with a CTA with perfusion or an MRI with perfusion to help select the patients that would benefit from this. But this has been shown for both alteplase and tenecteplase. Again, the medication was approved in 1995, and we're still finding ways to better utilize this medication. So this is really based on this concept of brain tissue at risk and the concept of collateral flow and penumbra. So when a vessel occlusion happens, there's an area of the brain that is not going to be receiving blood flow. And the further away on the vascular tree that this occlusion happens, the less collateral flow there is, meaning that same area of brain tissue might only receive blood flow from very few arteries because it's far end on the vascular tree, if you can imagine that. But if the occlusion is more proximal, then there's more arteries that can provide blood flow to that area of the brain. And the brain might be able to harness blood flow from some of these collaterals a little bit better. And that allows that area of the brain to survive longer. And that allows for longer treatment times. So it depends. Not every patient can benefit from thrombolytics or thrombectomy at later time windows. It's a combination of where the occlusion is, how the collaterals are, and so forth. But there are definitely many patients that can receive treatment out to 24 hours and most likely longer, and that's part of the studies that are being done now, and have a good outcome that before we wouldn't treat. So thrombectomy has really been evolving significantly as well over the last few years. The criteria have been, thankfully, being simplified as time goes by. So now we have data that patients can benefit from thrombectomy out to 24 hours. And we all know there's patients that can benefit beyond 24 hours. We see it in our day-to-day practice. And studies are ongoing to better delineate who they are. And this is something that you're going to see in the next few years, that patients can have thrombectomy for sure later than 24 hours based on advanced imaging criteria and trying to determine which patients have those collaterals, good collaterals, and can benefit at later time windows. We also now have good data that patients benefit from thrombectomy with basilar artery occlusions out to 24 hours as well, which before we didn't have much data on that. And even patients that have a large infarct already on CT scan. We're talking about aspects. There's a next slide where I'll go over what the aspect score is. But these are patients that have very large strokes that you would be very surprised to find out that they would benefit from things like thrombectomy or thrombolytics, but they do. And we have the data to prove it now with 6 randomized controlled trials. And then you don't need to use perfusion studies, meaning CTA perfusion or MR perfusion, to select patients for thrombectomy out to 12 hours from last known well. So you can just use the clinical evaluation and your plain brain CT to determine which patients could benefit from thrombectomy out to 12 hours. And this is something that's evolving, most likely, I think, as well. It will be expanded from 12 hours in the future. But this is great, especially for sites that don't have automated perfusion software, like it is available here. We use it every day. We have different companies that can do the perfusion, and immediately within a few minutes, you would get an estimate of how big the stroke is and what's the tissue at risk. And some countries don't have those products licensed yet, so they don't have access to it. Well, the good news is you don't have to use that to select patients out to 12 hours for thrombectomy. So this is the aspect score. It's a score that grades the area of injury to the middle cerebral artery distribution in the brain. It goes to 10. 10 is normal. And we said that patients with a score of an aspect score of 3 can benefit. That means that 7 of those areas that you see between the red and the blue and the yellow are injured, and they only have 3 of those not injured. Even those patients will have significant benefit from thrombectomy. So you can imagine what a powerful tool that is. And this just goes to show the effect of collaterals and time, and how there are patients that can sustain an area of arterial occlusion in their brain without big permanent damage for quite a bit of time. And what you see is the core, so how big the stroke is over time. And you can see on, for example, on the far right, diffuse and dawn. Those are studies that went to do thrombectomies out to 24 hours or so. And those patients selected patients, those studies selected patients based on their perfusion. So they were looking for these group of patients that have a small core, good collaterals, and can sustain over time. And you can see how these studies, these patients that participated in this study, were able to have a smaller core infarct over 24 hours or so, and progress at a much slower rate than an unselected population in other studies. So we know those patients are out there, and if we look for them, we can find them and help them and change their lives. Another innovation over the last year or so is surgery for intracranial hemorrhage. So intracranial hemorrhage hasn't been really benefiting from hematoma evacuation to improve outcomes based on data for decades. But now we have data from the ENRICH trial, which shows that minimally invasive surgery can really help these patients, especially for the lobar, so the hemorrhages that occur on the outer part of the brain versus the deep part of the brain. And you can see there what the selection criteria are for that study, but this really is a landmark study in the sense that it's the first study to really show a benefit of these minimally invasive evacuations to improve patients' function. I won't go into the details of this because of time, but there was another study. We say, well, yes, but there's the MIND study, and that's true. There's another study of minimally invasive hematoma evacuation that found no benefit. There are, however, key differences between the ENRICH trial and the MIND trial, which I highlighted here. One is the duration of time from when the patient was last known well to the treatment, and ENRICH treated patients much earlier. Also, the volumes of the hemorrhages, the location. So ENRICH really focused on the lobar hemorrhages, which is what really showed the benefit, is the hemorrhages on the outer part of the brain. And the MIND had quite a bit of deep hemorrhages, which didn't really benefit on the ENRICH trial. So there's some difference there. And there's going to be further trials needed to further better select the patient population. But it does seem that the ones that benefit the most from surgical evacuation are those with hemorrhage on the outer part of the brain, the lobar hemorrhages. And when we talk about secondary prevention of stroke, there has been a lot of changes in that arena. So we now have much better and powerful tools to control cholesterol, and atherosclerosis is a main driver of stroke and stroke recurrence. So we do know those that have significant arterial narrowing from atherosclerosis have a higher risk of having recurrent stroke. And now we have much powerful tools to lower cholesterol, especially in patients that are statin intolerant, such as PCSK9 inhibitors. And inclisiran, which is twice yearly dosing, right? So if you have a question whether your patient has compliance issues or so, that's a great tool to overcome that barrier. Then you also have better medications with proven cardiovascular disease benefit for diabetes and prediabetes. So you're just helping them lower the diabetes and improve their glycemic control, but also lower their risk of recurrent stroke. So we try to target those medications in patients that have experienced a stroke or a TIA. You have the GLP-1 receptor agonists, such as semaglutide, dulaglutide. So we use those quite a bit in patients, specifically if they have a BMI of 27 and another cardiovascular risk factor. SGL2 inhibitors, pioglitazone, and then there's combination antithrombotic therapies that can be tailored to individual patients to lower the risk of early stroke recurrence. So we have data on using combination of aspirin and Plavix, aspirin, Brilinta. There's some studies with aspirin or Plavix and cilostazol. There's also the use of low-dose Xarelto twice daily, so 2.5 together with aspirin. That can help significantly lower the risk of stroke related to atherosclerotic vascular disease. The Asundexian study was just found to be positive. That's with a factor 11 inhibitor plus an antiplatelet therapy. The publication is still pending, though. So that is a rapidly expanding field, and some patients will benefit from different combinations better. We also know that not everyone, Plavix doesn't work for everyone. So there's quite a bit of resistance in the community, especially for Asian populations, but not just in Asian populations. And now we can better test who those people are, so we're not giving them an antiplatelet that's not working for them, because Plavix is a prodrug, of course, that needs activation. So that is something that has made its way to our stroke clinic on a regular basis. We now have data from the CREST-2 study that carotid artery stenting for selected asymptomatic carotid artery stenosis, there's benefit for that versus endarterectomy or medical management. So that's a new innovation this year. There's enhanced tools to look for paroxysmal atrial fibrillation, which is a leading cause of cryptogenic stroke, stroke that looks embolic that you don't have a source for, whether that is with implantable monitors that you can use underneath the skin, such like the Link monitor, and there's a few others, to wearables like Apple Watch and some other monitors that you can wear that have automated algorithms to look for atrial fibrillation. So that will also help lower the risk of stroke in the future, especially recurrent stroke. We use surgical interventions to prevent stroke in the setting of atrial fibrillation regularly, whether that's with left atrial appendage closure devices or a combination of surgical closure of the appendage with ablation as well. And then PFO closure devices as well. So PFO closure can also help with stroke prevention, especially in young adults where there is no good cause for that stroke. This just goes a little bit on the combination antithrombotics, but I'm going to move forward in the essence of time. Mobile stroke units, you might have heard of this. These are little trucks equipped with CT scanners, nurses, CT techs, neurologists that could be in person or remotely via telemedicine. And that can help take the stroke care unit to the patient's location and be treated at the site. Or there's also different models where they can rendezvous with the ambulance halfway, all in attempts to obviously minimize the delay in providing acute stroke care treatment. And that really improves the odds of achieving functional independence. So MRS of 0 to 1, which is a very high bar of functional independence, is almost back to normal. 53.5 with the mobile stroke unit versus 45.5. And this is in a well-organized community. So the patients that don't have the mobile stroke unit are getting care pretty fast. And then it also has a lower 90-day mortality, actually. And the benefit is mostly for thrombolytics. In a well-organized stroke care community, like in this situation where it happens with Dr. Groth in Texas, the time for endovascular thrombectomy didn't significantly change. But for thrombolytics, yes. That's what's being delivered in the mobile stroke unit at the site, not surgery. So then we're also going into the world of AI as well. And this is some initiative. This is an initiative being taken from the Baptist informatics team with open AI so that the paramedics can use ambient, it's not open AI, so with ambient AI, so that the paramedics can talk as they're doing the examination of the patient, so they don't have to work on the tablet or on the phone, and the tablet automatically captures the information that's being said to do their pre-hospital stroke assessment to determine if the patient has a high probability of having a stroke, a high probability of having a large vessel occlusion, and then help them triage based on their geographic location and traffic to what is the closest stroke center that they need to go to, and then also send that information to the receiving stroke team. So we hope that we'll be able to implement that, in the future. And again, coordination of care is important because if you have all of these just siloed in your site, you're not going to be able to help the community very much. And that's something that we can help if you need to develop in your specific cities or hospitals. And with that, I will finish. Thank you very much.
So I've been here for 5 years, and I've seen the growth and maturity of Dr. De Los Ríos. And that was an example of somebody who knows their business, doesn't have to read the teleprompter, knows the information in detail. It's a great way to learn. So thank you, Felipe. Our next speaker is Dr. Diego Torres-Russotto. He's the chief of neurology here. He's a movement disorders expert, and he's going to talk about clinical insights and future research for the field of movement disorders. Diego.
Muy buenos días. So I'm going to be talking about advances in the field of movement disorders. And there is so much going on. And we are participating actively at the Miami Neuroscience Institute in precisely this, advancing movement disorders, or advancing neurology, advancing neurological diseases. So we're going to be covering only 4 of the 10,000 plus neurological diseases here, and that 4 movement disorders: Parkinson's disease, essential tremor, Huntington's disease, and dystonia. And then we'll review in general movement disorders. So movement disorders are very common. Look around you, between the person next to you on the right and the person next to you on the left. One of the 3 of you, one of them is going to develop a movement disorder. Who is it going to be? Yeah. Yes, yes. So I hope I gain your attention. You better be learning these things because we need the help. We all do, okay? And I'm talking only about the common movement disorders, not all of the movement disorders. Out of the common movement disorders, 1 in 3 people will develop it. So movement disorders are best cared for by multidisciplinary teams. And there are many reasons for that. They're extremely difficult to recognize and classify. We have developed the largest orthostatic tremor data set in the world here. Orthostatic tremor takes an average of 10 years to be diagnosed by a physician. So our patients are suffering for 10 years before they even get a name to the disease that they have. These diseases are very complex in terms of the differential diagnosis. Many treatment options to consider. There is an explosion of diagnostics and treatment devices and technology, and many specialty-specific procedures that only subspecialized people are able to provide. And lastly, I want to discuss the advancements in diagnostics that has been going way beyond just the physical examination as we used to do in neurology. Now we use advanced MRI systems like nigrosome testing, PET scanning, SPECT, DAT scan, SIN1 skin biopsy. We do a skin biopsy of the small nerves of the skin to see if the patients have the presence of alpha-synuclein, which is the protein that causes Parkinson's disease and 4 other diseases. So instead of now waiting to get an autopsy result to be completely certain of what is the diagnosis, we can have pathologically proven alpha-synucleinopathies diagnosed in a very easy fashion. Electrophysiology labs have been advancing to a completely new level. Motor unit labs are able to define myoclonus origin. Autonomic labs help us determine if the patient has an autonomic disorder of the central nervous system or the peripheral nervous system, and in that way differentiate movement disorders. Wearable devices are helping us understand what is the patient doing at home. It's not the same when you're seeing the patient in the clinic and they're in their best behavior. I don't know how many times the wives tell me, that's not how he looks at home. But that's why it's so important to use wearable devices so that we can see the real life of the patient. Genetic testings, from Huntington's disease to all sorts of other genetic disorders. Yesterday, I was talking with a patient that has episodic ataxia, and he was saying, I think I have one of those. How many are there? And I said, well, as far as I know, there are 8. I went to AI, and actually we are up to 10 now of these episodic ataxias, and we have genetic testing for them. And then cardiac MIBG, which can really differentiate Parkinson's disease from multiple systems atrophy and help us determine which are the best patients for deep brain stimulation surgery. So we have so many advancements in therapeutics, from the deep brain stimulation that is far from research. Right now is an extremely well-established treatment that transforms the lives of our patients. But we also have HIFU, and we have the only HIFU site in the entire South Florida region. We're going to be talking more about that, and Dr. Sporer will be expanding on that as well. Intrathecal baclofen pump can help with spasticity patients. Duopa pumps for Parkinson's disease. Subcutaneous pumps are now, came out last year and have been helping our patients with Parkinson's disease. Calatrio is a peripheral device that provides stimulation, electrical stimulation to the hands, and with that, dampens the tremor by 30 to 40% without doing any interventions or any surgeries on the patients. And then we have genetic-based treatments that are specific for the particular disease. An example, Skyclarys for Friedreich ataxia. So, we are moving really fast on the field of movement disorders. Levodopa, we always said is the most effective treatment for Parkinson's disease. Well, now think about that twice, because we have just so many options. Look at the many treatments that we have been developing over time. And guess what? When the patients are taking the medications and the medications are working, we call that the on time. But when the medications are not working, we call that the off time. With so many medications, the patient should be on continuously, right? or not, 92% of patients in a Michael J. Fox Foundation survey experience at least one off episode per day, and 20% experience 4 or more off episodes a day. How can you plan your day when you have Parkinson's disease and you're going to be having all of these times when the medication is not working and now you're frozen and you cannot move, right? And then you have all of the side effects. So, you know, the most common ones being dyskinesia, motor fluctuations, and other complications. So this is why medications alone are not going to be the solution for patients with Parkinson's disease. So what are the expected benefits of surgery for patients with Parkinson's disease? Is basically to stay on longer with less dyskinesias and less medication side effects. And this is why it continues to be a very important part of what we do and what we offer for our patients. So one of the options is Duopa. Duopa pump introduces levodopa in a continuous fashion inside the jejunum. It's an intrajejunal constant 24-hour delivery of the medication. And as you can see on the slides, it provides a reduction of off time by 4 hours a day, which is really comparable to deep brain stimulation surgery. And then we have DBS, and you know, it has been one of the nicest things in my work to be able to share time with my colleague, Dr. Aviva Bosch, both at the University of Nebraska, where we were working together, and now here. She will be talking a lot about deep brain stimulation for Parkinson's, so I'm not going to be discussing this. But I'm going to mention just one thing: how hard it is to get FDA approval for anything, right? Tell me, which single intervention in the United States has FDA approval to improve the quality of life? Deep brain stimulation. That's it, right? So imagine how powerful this surgery can be. And the real indication for this surgery is when you need more medication, but I cannot give it because then you will get side effects. But Dr. Bosch will be reviewing all of that together. And there are some risks, of course, related to the procedure. But the risks are usually very, they are rare. We're talking about, total complications, about 7% nationally. It depends on the site, it depends on the surgeon, and we're very, very lucky to have an amazing team here at Baptist Health. So let's talk a little bit about future research directions in Parkinson's disease, because this is the fun part. And I could not include all of the things that we are doing in Parkinson's. One of them is prasinezumab, which is a monoclonal antibody that is created to fight alpha-synuclein and be probably the first disease-modifying therapy for Parkinson's disease. And we will be part of that clinical trial here at Baptist. But HIFU palidotomy and pallidal tracts has now been approved for Parkinson's disease. And that is really an amazing advancement on the field. I'm going to be reviewing a little bit about that. And then we have multiple approved genetic insights and targeted therapy. For example, the drug on LRRK2 and on GBA that has been developed for Parkinson's disease, and is definitely a clear advancement in what we do. Now, we need to be considering genetic testing on all of the Parkinson patients to know if they have one of these genetic variants, so that we can then consider the opportunity to treat with these advanced treatments. Advanced imaging and biomarkers are reviewed, some of that already together. I think that the nigrosome MRIs have really changed what we do and how we think about Parkinson's plus syndromes, as well as the advancements on differentiating multiple system atrophy, progressive supranuclear palsy, and other PD plus syndromes. in particular so that we know how to best provide the counseling for our patients in terms of prognosis. And then digital health and remote monitoring is really exploding. And some of the companies have been doing incredible advancements internationally. Some couldn't really launch the program here in the United States. I was working on the PKG platform for more than 10 years, and then we were not able to really launch it from a market perspective. And then probably the two biggest advancements that we're working on in Parkinson's disease are on stem cell and on gene therapies. So stem cell therapies have been tried in Parkinson's for many years. The very first paper was published in 2001, and it was a disaster. Basically no benefit, and the patients were having horrific side effects. Now, with the new stem cells that we're using and the new studies that we are developing, we're having phase 1, phase 1b, and phase 2 data showing that stem cell is a viable alternative in patients with Parkinson's disease, and it can definitely, it has the potential to transforming the disease long term. So I'm very, very excited about that, and we're participating in a couple of trials on these, or we're trying to get into those trials as well. And then gene therapy is trying to lead to neurorestoration. So one of the studies that we're working on is on a viral vector that can take GDNF into the brain, expand it, and then, of course, help reduce the death of the brain cells in patients with Parkinson's disease. This is to remind me, so this is a patient of mine who underwent deep brain stimulation surgery for essential tremor. And sometimes people think, oh my God, brain surgery for essential tremor, and I am awake. Well, look at this lady. Isn't she looks wonderful, right? She's smiling, she's happy. This is one of the greatest moments in the OR, when you finally turn it on and you can give the patient zero tremor, no tremor at all, a perfect tremor control. And they're holding the glass, and for the first time in 20 years, they are not shaking. I think that essential tremor is one of the diseases that we are under-treating terribly in our country and in the world, for sure. HIFU can definitely improve patients with essential tremor. As you can see here, this is before the procedure and after the procedure. And the amount of tremor improvement at 1 year and at 3 years is truly dramatic. And as you can see, it is sustained, at least up to 4 years of data that we have now. So we are continuing to work on this, in particular on the long-term data to understand how essential tremor patients behave with HIFU. But it is a clear alternative to deep brain stimulation for some patients. This is not for everybody. And there are major differences between the two procedures, but it's good to have multiple options for our patients. In terms of innovation in tremor, we're testing novel pharmacological agents. We are advancing in neuroimaging to be able to understand the electrophysiological differences in the pathophysiology of essential tremor and other tremor disorders that are very hard to differentiate clinically. And then future essential tremor treatments are emphasizing precision dosing and precision combination therapies. For example, we are using combinations of drugs that we know work well, but that give side effects by eliminating the part of the medication that produces the side effects, and in that way help our patients better. And lastly, digital tremor quantification is helping us understand in an objective fashion how the patients are doing. Let's talk a little bit about one of my passions, Huntington's disease. Huntington's had a major major, big change in the landscape this year, and it's through the AMT-130 gene therapy. For the first time in our history, we get a positive phase 2 data showing a 75% slowing of the disease progression at 36 months compared to historical control. This is a disease that is lethal. It will kill you in an average of 20 years. And if we're able to delay by 75% the disease, it is really absolutely huge, to the point that the FDA has granted breakthrough therapy designation. And it's a relatively simple treatment. We're doing a one-time MRI-guided surgery that delivers the AAV5 vector into the neostriatum. And then in that way, we're delivering a microRNA that is stopping the messenger RNA of Huntington protein to be produced, and therefore a significant reduction of the abnormal protein, and therefore transforming the lives of our patients. I'm going to end with dystonia. And dystonia, basically excessive muscle activity, is extremely common. So, but terribly underdiagnosed. It produces abnormal postures. It can produce tremors. In fact, I always joke that dystonia is what pays for the college of my kids, because I get so many patients referred to me for essential tremor, and then when I examine them, I realize that the reason why the previous essential tremor treatments are not working is because it's not ET, it is dystonia, right? It is a common misdiagnosis, and one that is important to differentiate because we can do a lot about. We have therapies that are specific to dystonias, oral medications, injections, and even surgeries that can help us with this condition. Showing here a picture of a patient of mine took these pictures and then he shared them with us. He has blepharospasm, so a difficulty keeping the eyes open. Blepharospasm closes your eyes. And we did botulinum toxin injections, and you can see he's trying to open his eyes as much as he can. On the first two pictures are, the first two pictures are on weeks 1 and 2, and you can see how after botulinum toxin injections on week 6 and 7, he's able to open his eyes normally. And this is a patient with severe anterocholitis, and after receiving botulinum toxin injection, he can have a normal posture of his neck. Also a severe patient, a severe cantocormia with Parkinson's disease, and after receiving injections, the patient is normalized. Big news for us in our field is that after so many years, FDA has provided expanded deep brain stimulation labeling for dystonia. And what a wonderful news that is. We have been fighting for this for more than 20 years. Dystonia transforms the lives of patients, and deep brain stimulation transforms dystonia. We can make such a huge difference on our patients, and now with this approval, we can really do a lot more because the insurances have to cover it, right? It's not the same as when it was just a humanitarian device usage. There are so many advances in dystonia. I'm listing here some. We are participating on the VIMA trials. There are 2 trials here. And for example, this is a designer drug where we use trihexyphenidyl to treat patients with dystonia. And then another one that I wanted to really talk about is closed loop deep brain stimulation systems for the treatment of dystonia, which is really under a lot of research lately. There is so much going on, guys. I'm so excited about movement disorders and what we're doing, and I really want to thank you for your attention. Thank you.
All right, so I'm taking moderator decision, and we're skipping my lecture because I have another one at the end, and we're going directly to Dr. Bosch, who's going to talk about surgical treatment of Parkinson's disease, latest techniques.
In the next 90 minutes or so, no, just kidding. So my job today is to talk about surgery specifically for Parkinson's disease. Those are my disclosures. I have NIH funding for some of the work I do in Parkinson's disease, and I am a consultant for industry, which is how we push the field forward on behalf of our patients. That's my outline, and a bit of a review about Parkinson's disease. Some 50,000 new patients per year diagnosed with Parkinson's in the United States, and that translates into a prevalence of 1.5 million in the United States, 12 million worldwide, but it's increasing. It's expected that by 2050, there will be over 25 million people worldwide with Parkinson's disease. It results from the loss of neurons in the central nervous system that secrete dopamine, that produce and secrete dopamine. And that loss of dopamine leads to a progressive impairment in movement, consisting of the resistance to movement or rigidity, the slowness of movement or bradykinesia, and the tremor of Parkinson's disease, different from the essential tremor that Dr. Torres spoke of. It's treated with replacing dopamine with synthetic dopamine and dopamine agonists. But unfortunately, the treatment also results in side effects. So dyskinesias, the extra movements that patients get when they've been on dopamine replacement therapy for a while, and the progressive motor fluctuations and freezing episodes that patients get that are so problematic in terms of predicting how your day is going to go. And there are many patients who are intolerant to the medications that are necessary for treating their motor symptoms. There was a tremendous breakthrough in the latter half of the 20th century, in the late 1980s, with a group, unfortunately, of drug addicts in California who were taking a synthetic version of Demerol and wound up with a Parkinsonian syndrome. From that experience, we learned that we could model in the laboratory Parkinson's disease in non-human primates using 6-hydroxydopa or MPTP. So a substantial breakthrough on the, but somewhat tragic, on behalf of our patients. Parkinson's disease, when it comes to diagnosis, we're focused on the motor symptoms. And those are the tremor, the resting tremor of Parkinson's disease, the slowness of movement, the dyskinesias, which start within 3 to 5 years of implementing medication therapy, and the rigidity. As you heard from Dr. Torres, the first line of attack is the medications, replacing the dwindling dopamine supplies. And you see the various classes of compounds that are used to treat Parkinson's disease right now. Dr. Torres also mentioned various biologicals that are coming forward from a research standpoint, none of which have passed FDA approval in the United States yet, but there are some very interesting results from these various trials, and it's really worth staying on top of because of the possibility of pushing the field forward. And you see them represented there. There are gene therapy trials, antibody trials, and then neurotrophic factors that are in trial. As a surgeon, I am interested in this because so far these biologicals require surgical delivery. So why do we have surgery for Parkinson's disease if the medications work? Well, as I said, levodopa, although the mainstay of medical therapy for Parkinson's disease, over time, patients develop worsening on and off motor fluctuations despite these necessary medications. And over a quarter of our patients have debilitating motor symptoms even with the medical therapy. So they continue to have tremor, for instance, which interferes with their activities of daily living. Levodopa is associated, as I said, with intolerable side effects. There are dose-limiting dyskinesias, those extra movements that you see in Michael J. Fox when he makes his television appearances today. GI symptoms, hallucinations can all happen in our patients. So going back to the middle of the 20th century, with the creation of stereotactic radiosurgery and gamma knife therapy, patients were treated with lesioning. So we would make, neurosurgeons, not me, I wasn't around yet, but neurosurgeons would make a hole in the brain, in the thalamus, or in the globus pallidum to treat Parkinson's disease. And it's an effective treatment. But you all know that when you make a hole in the brain, that tissue doesn't come back. So if I am in what we euphemistically call a suboptimal location, which means I got the hole in the wrong place, that tissue doesn't come back. Those side effects are permanent. And so lesioning is powerful. It can be very effective, but there is a downside. There is a cost. Lesioning has come back in a big way, as Dr. Torres mentioned, in the form of MR-guided, high-intensity focused ultrasound. It is a lesioning technique. It makes a hole in the brain. You have to have your whole head shaved to have HIFU, and some patients won't tolerate that. You do have to be awake. There's a test dose, if you will, of ultrasound that tells us if we're going to get a side effect, likely, or if we're in the right location to stop tremor, for instance. It's been approved by the US Food and Drug Administration to treat tremor-dominant Parkinson's disease. That goes back to 2018. In 2021, unilateral pallidotomy was approved for the treatment of Parkinson's motor symptoms, the bradykinesia, the rigidity, the dyskinesias. And then in 2025, very recently, it was approved for staged bilateral lesioning of the pallidothalamic tract in Parkinson's disease. Now, there are no randomized controlled data that's reasonably powered that compares DBS, neuromodulation that does not make a hole in the brain, with lesioning from HIFU. It's a very difficult study to do. That doesn't mean that it won't happen. But there is randomized controlled trial data that looks at blinded sham HIFU versus actual HIFU. And those data indicate that it's highly effective, but it does have complications of the lesion, as you would expect. There are adverse events associated with brain lesioning, and there are adverse events specific to HIFU that include the creation of skull lesions that we don't fully understand yet, because you have multiple ports through which ultrasound is delivered through the skull. And then it is, on the whole, in the aggregate, it is cheaper than implanting a DBS device that requires battery changes every so often. Even the rechargeable batteries have to be replaced with time. The nice thing about HIFU is it's one and done. You create the lesion, you don't ever have to take the patient back unless their symptoms recur, and symptoms do recur. What we do is we discuss with the patients what's available, what the upsides and the downsides are, and we involve the patients, obviously, in the decision of how to proceed. And the New England Journal of Medicine article there, led by Jeffrey Elias and colleagues, that study is the randomized controlled trial that I mentioned and is worth taking a look at. I described the results of that. So moving on from lesioning to neuromodulation, again, we're not making a hole in the brain, we're modulating brain function. Also an old technique, it goes back to the middle of the 20th century. And there have been many advances in the technology over those years, the same as with lesioning. There have been many advances. I will describe some of those advances as I go forward. But the interesting thing for us in the United States is the entry into the FDA approval status, and therefore into the marketplace for us, of 3 device manufacturers now in the United States. So Medtronic was the earliest, then followed by St. Jude, Abbott, and then by Boston Scientific. And so we have the option of various manufacturers for DBS. And that's good for patients because it creates competition between the manufacturers for improving devices. There are an expanding, I've updated this particular figure probably 5 times since I first created it in 2015. And there's an expanding number of indications for neuromodulation that just permeate the nervous system, both central and peripheral nervous system. There's a global neuromodulation market that is enlarging. It's billions of dollars and rising. And with big names in industry jumping into the field of neuromodulation, it has pushed forward at least the interest in the field, if not what we can actually deliver as yet. So is deep brain stimulation effective for Parkinson's motor symptoms? There is quite a lot of randomized controlled trials that say yes, and that the effect of the benefit for motor symptoms is sustained over the long term. So we continue to replace the batteries in patients with Parkinson's disease who were implanted in the 20th century, and they continue to help. A picture is worth 1,000 words, but a video is probably worth more, and the woman on the left of the screen, a small animal veterinarian with Parkinson's disease. You can imagine it's hard for her to do her work if she's frozen and unable to move. On the right, she obviously didn't like my haircut. She's got a cowboy hat on, but she's able to move quite well. There you go. And so Parkinson's disease with DBS and without DBS. So there are many ways to do the surgery. I won't bore you with the details. It's a great therapy, but there are problems, which is to say opportunities in what we can provide for patients with DBS. Point number one, patients have to be awake for surgery. And Dr. Torres showed you that smiling patient having her tremor relieved. That's certainly true, but there are plenty of patients who don't want to be awake in a head frame in the operating room with me operating on them. Paul Larson and Phil Starr at University of California, San Francisco came up with a very clever way to put patients asleep in the MRI scanner, intraoperative MRI, and by visualizing the target, put the electrode into the right location. That led to a company that allows us to do that very slickly in an intraoperative MRI. So patients asleep, we're using target-based imaging, and that allows us also to account for brain shift because we're able to image the brain shift as it happens when I open the dura and CSF emerges. Now, the downside is I have to operate within an MRI scanner, which leads to all sorts of headaches. And when you're using imaging-based targeting, well, it turns out you can't see the image clearly in everyone. So it's not 100% useful. The other issue is, I've talked about the motor symptoms of Parkinson's disease, but is that all of Parkinson's? No. There are many, many non-motor symptoms of Parkinson's disease that can be quite debilitating. In fact, Parkinson's disease affects every organ system in your body. In particular, when you think about the onset of the motor symptoms, let's see if I can get the fancy, there it goes. All right, so this is time zero when Parkinson's disease comes to attention. Does it show up on both? No. This is time zero when Parkinson's disease comes to attention because of the motor symptoms. But there's a good 2 decades ahead of that where symptoms are accumulating and we as clinicians are not aware of what the problem is. It's the terrible sleep fragmentation and other sleep problems associated with Parkinson's disease, the chronic constipation, the mood changes, et cetera. And if you look at those non-motor symptoms in the aggregate, they are more burdensome for Parkinson's patients and their caregivers than the tremor, the rigidity, and the bradykinesia of Parkinson's disease are. And we don't treat them. You know, the medications don't do anything. We can give sedative hypnotics for the sleep problems, but that just masks the problem. And so we tend to ignore them. But the problem is that, as I said, these are very burdensome for the patients. And Michael J. Fox has gone on record, American actor, gone on record as saying that he doesn't want neuromodulation or, for his disease. He wants a cure. And why wouldn't you want a cure? You want something that fixes the totality of the disease, not just the things that we can treat. So other issues include the DBS programming. DBS right now, deep brain stimulation, is what's considered an open loop therapy, which means I do a fabulous surgery. Patient goes to Dr. Torres' clinic. Dr. Torres programs the patient, which is to say he looks at the patient in their off state, programs the device to deliver stimulation that suppresses the motor, treats the motor symptoms, and does not cause side effects, and then sends the patient on his or her way. The device doesn't know what's happening in the patient's body, doesn't know that the patient's asleep and therefore doesn't need stimulation, doesn't know that the patient is between medication doses and should ramp up, or patient now has dyskinesias from the combination of the stimulation and the medication and should ramp down. It's an open loop therapy. That has implications for personalizing the treatment of the disease, and I'll come back to that in a minute. The parameter space for programming is quite large, particularly now that we have steerable contact, which is to say 8 contact electrodes. And it's semi-subjective, the whole process. We're relying on the patients to tell us what they're feeling, what they're experiencing. It's time-consuming. It requires the patients to be off medication, requires tremendous expertise. So when I think about the future of neuromodulation for Parkinson's patients, I think about refining the existing technologies, taking what's a good device, a good treatment, even though I've spent the last 5 minutes criticizing it, and figuring out how iteratively we can improve it for our patients. But also I think about looking at the things that we don't currently treat, those non-motor symptoms, for instance, in Parkinson's disease, and how we figure out treatments for those. So in terms of refining the existing technologies, there's been a lot of effort in the last decade that has gone into improving electrode design and improving the smart batteries, if you will. When I am attempting to put the electrode into the right location in the operating room, I'm looking for something like this, where the electrode is sitting in the motor territory of the subthalamic nucleus, and it's far enough from surrounding structures that when the neurologist activates the device and it's spreading current the way it's supposed to the subthalamic nucleus, it's not spreading current to those surrounding structures. And that way I won't get side effects and I'll get benefit on behalf of the patient. But what if, instead of getting the electrode perfectly on this axial image into the right location, I'm a little off? And now the current can spread to fibers of the internal capsule and give the patient terrible side effects. Well, a few years ago, the only option we had for the electrodes we implant were these types of cylindrical contact electrodes. And what these electrodes do is they spread current in a cylindrical fashion, a spherical fashion around each of those contacts, something that looks like this. But if you can break that cylindrical contact down into, say, 3 independent shields and turn on or turn those off independently, you can then steer the current, if you will. And that's been a huge game changer for us as surgeons trying to get the electrodes into the right location. And I should say that the STN is a tiny structure, 6 millimeters in maximal extent one way, 4 millimeters another way. Changing the way we can apply current has also been useful for the people programming, the neurologists programming these devices. And I won't bore you with the details, but there are now the ability to interleave and cycle the stimulation to help patients with benefit and side effect. Finally, closing the loop. As I said, this is currently open loop therapy, neuromodulation for Parkinson's disease. But what if we could find a biomarker in the brain that told the device, informed the device that the patient was asleep and therefore the device could turn down or turn off, or told the device that the tremor was coming back and it needed to increase stimulation? Well, that would be very useful for our patients, and that would help with programming. It could tailor the therapy specifically for the patient's day-to-day existence, prolong battery life by ramping down when it didn't need to be at full dose, decrease morbidity, and ultimately create a self-programming device. We have such a device actually in epilepsy surgery, another thing that I do. And you see it implanted in that patient on the right side. That's called a responsive neural stimulator. And what's happening is that device is targeting, every time it sees the patient having a seizure through this electrode, it turns on and stimulates the focus of the seizure onset. So that's a closed loop device. It's sensing something, some relevant biomarker from the patient's own brain, and then delivering a therapy based on that. So there is work now underway looking for such biomarkers that are relevant to Parkinson's disease, the motor symptoms, and the non-motor symptoms. And I won't belabor the point, but these data already exist in the form of non-human primates and have been translated into a closed-loop, capable, clinically available DBS battery in the last 2 years or so. So there are also additional types of neuromodulation, which I don't have time to go into today, but they include things like optogenetics, where we can turn on and turn off elements of the nervous system. Low-intensity focused ultrasound which helps us to open up, permeabilize the blood-brain barrier and get into the blood-brain, through the blood-brain barrier into the central nervous system, interesting biologically active agents. Magnetic neuromodulation, which relies on the endogenous metal in the brain, metal molecules in the brain, and closed-loop DBS, as I mentioned, and the search for relevant biomarkers. So very exciting time to be in this field as a neurosurgeon. There are some ethical concerns that are undoubtedly raised by the things that I've discussed, such as, are we mitigating disease as opposed to enhancing the central nervous system? The risks and safety posed to patients. Protecting our data, and the data of our patients, specifically from a security standpoint, how we select patients, how we allocate resources. These are not cheap therapies, as you can imagine. The whole issue of informed consent and making sure our patients understand what the risks and benefits are, their autonomy, their ability to control the devices, and then are you changing personality or self-identity? I will say that if we could actually change personality with any of these devices, I'd be signing some of my colleagues up for them. It's not actually how it works. And then the whole issue of enhancing function. So with that said, what do we need going forward? Patients want a cure, and that work is going on all over the world, and hopefully this will be a different story in a year or two. Continued improvements in the good tools that we already have in our toolbox, partnership with industry for the devices that will make a meaningful impact on patient lives, and a twin focus on pushing forward the existing technology and developing the next generation devices with appropriate ethical guardrails. Thank you so much for listening.
All right, thank you, Dr. Bosch. Next speaker is Dr. Guilherme Dabus, who's an interventional neuroradiologist. He's going to talk about mechanical thrombectomy in stroke. Thank you.
All right, Mike, thank you so much. Very hard to follow Dr. Bosch, brilliant presentation, but let's go. First of all, it's great to be here. It's really a pleasure to see some old friends and meet new friends. Thanks, Baptist International, for putting this together. So basically, we're going to be talking about acute stroke thrombectomy. So a little bit different. We're talking about now emergency stuff. So, oops, sorry. Okay, let's go. So basically, these are my disclosures really quick. So it's important to understand, first of all, what kind of burden stroke really is to our society, right? So it's one of the main causes for mortality. But more important than that, really, is the fact that it results in a lot of loss of work, loss of pleasure in life, loss of a lot of things, particularly like with estimated costs of about $7 billion for direct and indirect costs to our society. It's very critical that we find ways to address this in a more effective way. This is a slide I think is very interesting. It's one of my presentations for many, many years. And I think it's, I'm trying to make a point of this, the fact that this came out in 2006. And if you look at that, in 2006, there was a prediction that the number of strokes would just continue to increase. What that means is there's a lot of things that could be done to decrease that incidence of strokes. And if you look into this graph here, it will tell you that if nothing was done in 2025, which is the year that we are on, we would have over 1.1 million strokes a year. And actually, we kind of became stable around 800 to 900,000 strokes a year. So what that means, well, there's a lot of things that changed throughout the years. People were more conscious, people were exercising more, people are taking better care of themselves. There's a lot of new medications that were available, a lot of hypertensive medication, a lot of statin that became a big player for acute stroke management, particularly in patients with intracranial atherosclerotic disease, heart disease, a lot of new anticoagulants. So I think that's actually a proven that if we take care of ourselves, we can decrease the incidence of pretty burdensome diseases such as acute stroke. Now, when we're talking about thrombectomy, it's important to see where thrombectomy fits when you're having acute stroke. So if you look into this graph here, approximately of all the strokes, of course, we have mostly like the ischemic strokes, which accounts for 80 to 85% of all the strokes, if you talk about stroke as a lay term, and of course 15% which are hemorrhagic. But of all the ischemic strokes, about 40% may be due to a large vessel occlusion. And large vessel occlusion is the main problem and the main target for thrombectomy. Why? Because we know these patients usually don't do well with medication. They usually don't do well if nothing is done. So these patients need to be recanalized as fast as possible. When we're talking about thrombectomy, we've been studying this for many, many years, since the late 90s. Actually, at UCSF, studies with pro-urokinase done like in the 90s actually showed benefit of the treatment, but the urokinase was never approved by the FDA, who knows why. Then we moved into what we call like the mechanical phase of thrombectomy, right? So basically we start studying. First we had this device that looks like a corkscrew, which was the Mercy device. And then really things start to change really more recently around like 2010 when by an accident, someone in Europe using a stent that was made to do stent-assisted coembolization saw that it was a great device to do thrombectomy. You place that across a clot and you pull it out open and the clot comes with it. So that actually was really what changed everything. And if you look into this timeline here, we had a lot of years that we were studying, we're trying devices, the devices were not very good, we didn't have great results. And as I said, in 2013, there were 3 NIH or 3 randomized controlled trials that almost put a stop in all thrombectomy. And why is that? Because we were doing all these trials with older technology, with older devices that were not very effective. And the good thing is that we're persistent. I mean, interventionists in general are persistent, you know, and we keep going and we keep trying new devices. And then thankfully, in 2015, we really had the big boom in thrombectomy where like all the trials, like 5 randomized controlled trials were published simultaneously, demonstrating big advantage of thrombectomy compared to medical management for patients with large vessel occlusion. So it's really where we are right now. So what did we learn? Mr. Clean is a hallmark study. It was the first thrombectomy study that really proved benefit of thrombectomy compared to medical management. But we learned a lot of things. So it's important to understand, again, why do thrombectomy? Why expose these patients to this type of treatment? Well, because these patients don't do well if nothing is done. And you can actually see here the prognosis is quite somber if nothing is done, if the vessel is not recanalized. Other thing that we learned, TPA on that part and tenectoplase, they work to a certain extent, but for large vessel occlusion, because the clot burden is larger, they usually don't do a great job. They help, but they're not a lot of times able to recanalize those vessels. So basically, that's where you need to go in mechanically and actually remove it. The other thing that we learned, of course, the better patient selection. If we select the patients right, we're going to have better success. The other thing, the faster we do these procedures, the better chance these patients have of having a good outcome. That's critical. You know, we screen patients to 24 hours. That doesn't mean that you can wait 24 hours to do a thrombectomy with a patient. That just means that we're screening that. If the patient comes in 1 hour later, we need to treat it 1 hour later. If the patient comes in 24 hours and it's a screen and we think that there's still tissue to be saved, we're going to go ahead and do it. So the 24-hour window that we call, the extended window, it's just the fact that we can screen them up to that because a lot of times these patients were less seeing normal way before, right? So what that means is that the stroke, we don't know when it happened. We're just screening them at 24 hours. So I think it's very important to not really misconstruct this idea and think that, oh, we have an extended window of 24 hours, so we can wait and, 12 hours from now, we're going to go ahead and do it. No, you need to be treated right away. The faster we do, the greater the chance of this patient doing well. The other thing that we learned is that recanalization is a predictor of good outcome. If the vessel is open, that's what's going to give this patient the best chance of doing well. This has been shown in multiple studies from the early 2000s with the Mercy, multi-Mercy, with ProRecanise, which was the PROACT study, of course, and all the stent retriever and aspiration studies proved that very clearly. We can actually see here in IMS3, which was one of the negative trials. NIH-sponsored negative trial in 2013 almost killed thrombectomy, which would be a catastrophic event. But you can actually see here, one thing that they show when they kind of open up the study is that really the patients that did had good recanalization, they did much better than the ones that didn't. So that actually, brought up like a new marker, which is, actually this is a study that we published in 2013, I was a co-author here, that actually says exactly the same. We changed the way we classify actual recanalization, number one, and we start to understand that you need to have at least 50% of the MCA territory recanalized for this patient to have a good outcome. Of course, the greater, which is what we call like a TK3, which is a perfect recanalization, is what gives this patient the best chance, but everything above 50% starts to improve significantly the chance of this patient doing well. The other thing, this is a very interesting study. This is a study that has been repeated over and over and over. This study here, this graph shows a very interesting thing. It shows that for every 30 minutes that someone has a large vessel occlusion, the chance of this patient doing well, have a good prognosis, decrease 10%. So think about it. Someone showing up 2 hours later, the chance of this patient doing well is already starting at 60%. So this basically, that shows how important we need to be and how fast we need to go into like having this treated. And why is that? Because the concept of acute stroke is actually fairly simple. Of course, the mechanism and everybody's different. The autoregulation is different. The collateral circulation is different. Patients are different. But in general, when you have a large vessel occlusion, you have here, for example, this, I don't know. Well, either way. So basically what happens here, you here have a drawing where we have like an M1 occlusion, right? So when you have an M1 occlusion, immediately they start to form a core. So what that means is that the vessels close to where or the tissue close to where their occlusion is, it starts to infarct, it starts to die, right? However, there's usually a big territory which is still be kept patent or viable, symptomatic, right? So the patient has symptoms, but is not dead yet. And that's the target of thrombectomy. So when you go in and you open that vessel, all that area, which we call penumbra, is the area that really you reestablish the blood flow. That patient was symptomatic for that. But when the blood flow is reestablished, this patient, that part of the brain which was not functioning, but it was still viable, goes back to life and starts to work normally. The core is the core. The core is part of the brain that is already dead. You cannot change that, but the idea is that the smaller the core, the better for that. So really, as I said, a lot of things start to change for us. The first stent retriever was approved in 2012 in the United States, and then when things really changed, and then we had a really like an avalanche of new devices coming up, aspiration catheters coming up, bigger and bigger devices that are more safer to use, and really was when we really started to have like a more effective recanalization for this. And as I said, a lot of trials which were published all together in 2015. This is the main study because this is the Mr. Clean. Was the first one to really be published in the New England Journal of Medicine. Really showed the benefit of it. You can actually see here. The benefit was not great. I mean, the numbers were much better than if you do anything, but nowadays our results are much better than what Mr. Clean showed. And then, of course, there was a domino effect, and then all the trials started being published and showing, you had Escape IA or Escape here in the US and in Canada, and then you had Extend IA in Australia, and then you had Swift Prime here in the United States, and then you had Rivascat in Spain, all demonstrating, again, the vast superiority of endovascular treatment. And why is that? So this is a very interesting study. This is what we call like a Hermes collaboration. So that's basically a pooling analysis of all the randomized trials. And what this shows is the main predictor of poor outcome is actually the final infarct volume. So of course, it makes sense. The bigger the infarct, the lower the chance of this patient doing well, right? I mean, what you want to have is a small infarct, so this patient has more brain normal and functional, right? So you can actually see here very clearly. So the greater the volume of the final infarct, the lower the chance of this patient is doing well. So, and for us, and I know Dr. McDermott sometimes very passionate about it, the way we still measure outcome in stroke is through the modified ranking scale. And for us, any good outcome is someone when you have like a modified ranking scale in 90 days that is 2 or less. So 2 is like some symptoms, but able to function normal, do everything that he was able to do above. 6 is death. So 3, 4, and 5. 3 is kind of borderline. So some people argue against that, but 4 and 5 is really bad outcome. Of course, 6 is death. So that's important to understand. What you want is the lowest or the smallest amount of final infarct volume. That's what gives the patient the best chance of doing well. We had extended windows then. As I said, we had studies that were tested up to 16 hours and then 24 hours, and they also showed the big benefit of thrombectomy compared to medical management. They're very published in that. So basically, this is a table that I made just to show when you have like a comparison. You have all the randomized control trials, you have the revascularization rates, and you have the MRS there. You can see here on the interventional arm compared to the medical arm, those patients do statistically significant much better when they are treated with thrombectomy. Now, so, just going back, I mean, recanalization is really important. Now, we have a lot of devices. So when this device started to all come up, there was a lot of discussion. There was like people that were favor like stent retrievers, and others that were like, oh no, aspiration is better. And the great reality is that it doesn't really matter. What matters is that you need to go there and open the freaking vessel. That's what's going to change the patient's chance of doing well. Put a stent, whatever, I don't care. You need to go in and open the vessel. Again, as I said, this is a study that was replicated that for every 30 minutes, you decrease 10% the chance of doing well. The other thing here, very clear, this is also from the Hermes collaboration. Again, the longer it takes to recanalize the vessel or the longest the patient presents to the hospital, the lower the chance of this patient doing well. As you can see, again, measured by the modified ranking scale. So those are the stent retrievers that we still have. There's some new ones, and then aspiration catheters. There was, again, a question which one performs better. And actually, we tested that. This is the COMPASS study, which was actually published in the New England Journal of Medicine. And we were part of it and actually showed really no difference of aspiration versus stent retriever for recanalization of those vessels. One thing that we do learn, and this is another paper that we put together with some collaborators, is that if you can go in and do the reperfusion in one pass, we call this the first pass effect. That's when these patients have the best chance of doing well, as we can actually see here. So again, the more passes you need to do, passes we consider trying the thrombectomy. So the more you do, you start to decrease significantly the chance of this patient doing well. So if you can go in and open the vessel in the first pass, that gives the patient the best chance to do well, as actually you can see here. So just some quick examples. This is a patient presented with an ICA-T occlusion, as we see here. So you see here, you don't see the MCA or the ACA. You see a big fetal posterior cerebral artery there. We go there. This is a stent retriever place. All these little dots are markers, so we can actually see them on fluoroscopy. And you see here the clot that comes out, and you have like full reperfusion of this patient's vessel. Another case here with aspiration, M1 occlusion on the right side. We advance that catheter. The tip of the catheter is the aspiration catheter. We go into the clot. We aspirate that clot. The clot comes out, and the patient's vessel is fully reperfused. So, I mean, those are very good techniques, and they all work. Now, one thing that we learned from all the trials, too, is that we were being very, very selective. And this here, if you look into all the trials, it shows that the more selective you are, even the medical arm starts to do better, right? So this points to a question that we had, kind of a little bit of a conundrum, which is, okay, we are being very selective. Our results are getting better and better, but we're not helping as many patients that can potentially be helped, right? So the more patients you help, your percentage of patients that do well will decrease, but you're helping, a greater number of patients that do well. So, we came a lot of things, again, there's a lot of questions that were raised because of that. So, should we continue to be very selective and tell people that we have outcomes that are like 60, 70% now of patients doing well? Or should we treat like everyone? And then if they do well, great. But if they don't, so be it. At least you gave them a chance. And there's a lot of studies that were done for that, right? So unfortunately, there's some cases that they don't do well. This patient comes in with an M1 and a PCA occlusion altogether. I did a thrombectomy of this patient. You see the clot there, both clots, full reperfusion. But unfortunately, some patients are fast progressors, and they go and develop like big strokes. It's important to have a real multidisciplinary team taking care of these patients. Have ICU be on top of it. Neurosurgery be on top of it. This patient, of course, did need a decompressive craniectomy. And, unfortunately, it's a life-saving procedure, and it actually increased the chance of this doing well. Age limit. This is a case that is a very old case of mine, actually. This patient was 112 years old. I didn't treat this patient, okay? I said it's actually, no. Unfortunately, no. Felipe wanted me to treat him. I said, no, I'm not doing this. But I did treat a 99-year-old one time that did fairly well. Now, those times were different, to be quite honest. That 112-year-old gentleman was very early when we were here. We didn't have good devices. This one actually did fairly well. 99-year-old, M1 occlusion, full recanalization. Vessels look beautiful for a 99-year-old. I mean, is this what needs to be done? I don't know. There's questions. I think it's something that we can definitely discuss. What about distal occlusions? Distal occlusions are very tricky. One, because a lot of times when they come up, depending on, like, for example, if you have an M2 that is dominant, you may have symptoms like an M1, and those patients need to be treated. But distal M2s, M3s, it becomes very tricky. Actually, there's 4 trials that were just published this year, early on, that didn't show any benefit and show increased risk for distal thrombectomy. And so, unfortunately, right now, we're waiting to see if there's going to be more trials that will come up and show some better results. So you see here, this is a distal occlusion. This is a thrombectomy that I did. The patient did well. But, it's hard to know if these patients will do well or not. And at this point, probably we shouldn't be doing that anymore. We should wait for new data. As I said, so those are just the results. I'm just going faster because of time. So believe me, those results showed no difference of the endovascular treatment versus the patient we treated medically. What about patients with low NIH stroke scale? That's tricky for us. Sometimes you get a patient that has an M1 occlusion and has a stroke scale of like 2, 3, almost normal. So this patient, you cannot make anything better, and that's a little bit tricky for us. And it becomes a problem. For example, you see this case here, 7-year-old, M1 occlusion, big perfusion mismatch, stroke scale of 1. What do? If you take this patient to thrombectomy, either he will come out exactly like he was before or worse. You're not going to make him better, right? So a lot of times we wait and see if this patient deteriorates, then we'll take him for thrombectomy. If not, 50% of patients don't get worse. They stabilize like that. So I think that's one of the good things to keep in mind. So another thing that is a little bit tricky. What about large core infarct? So large core is a patient that present already with a big infarct. So what do we do for them? Well, there's a lot of studies that were done actually recently that show that although these patients usually don't do very well, they do better than if they are not treated. So that's one of the things. So there's a treatment effect. That doesn't mean they will do well. The difference becomes like 20% of them doing well versus 8% doing well. So we are more open now to treat patients depending on like a lot of young patients and things like that to do the thrombectomy. Like for example, this case, a young patient, 50-something-year-old with an ICAT occlusion, already with a large core. I did a thrombectomy with this patient. This patient actually did amazing well, even though that she had a big stroke. She had some expressive aphasia, but her NIH stroke scale was 4, like a few days after. So again, we're trying to help more patients, even knowing that a lot of these patients will not do well because they already have a big infarct. Basilar occlusion, one of the worst prognoses, acute basilar occlusion mortality is over like 92, 95%. So those patients also need to be treated, okay? We now have a lot of trials that really show the benefit of thrombectomy for acute basilar occlusion, particularly from China, that show the good benefit, as you can see here, for those patients. Like this case here, basilar occlusion, thrombectomy done, and basically have a recanalization of the distal basilar. Future, well, the next minute, I'm just going to say that of course, I don't have a crystal ball, but there's a lot of research being done right now. So there's research being done with larger superbore catheters. I was the national principal investigator for one of the trials that was published recently in stroke. There's a lot of data coming up from this larger new bore catheters showing good recanalization, safe of use. Also, like another thing that is probably going to be important in the future is neuroprotection. There's a lot of compounds being tested. This is a compound that we've been working for some time now that, again, hopefully can show some benefit. But we don't know. There's been a lot of tests done with like neuroprotective agents, and they all had failed so far. So people are always coming up with new ideas and new stuff. So basically, to conclude, I think organization of strokes of care is critical. It's important to be in a system in the center, that you have great relationship with neurosurgery, neuro-ICU, neurology, interventional. It's really working together to provide those patients the best chance of a good outcome. Again, the main message here for thrombectomy is that the vessel needs to be open as fast as possible. That's it. I mean, there's no secret about that. You need to go in fast, open the vessel fast. That's what's going to give this patient the best chance of doing well. And again, let's be carefully less selective to treat more patients and try to help more patients. I appreciate your attention, and I think the future is very promising for these patients. Thank you very much.
Thank you, Dr. DeBoos. Only 40 minutes to the break. Hang in there. Next speaker is Dr. Michael Gomez, who's going to talk about minimally invasive lumbar spine surgery, indications and outcomes. Michael.
All right, good morning. I'm Michael Gomez. I'm one of the spine surgeons with Miami Neuroscience Institute, and I'm here to discuss minimally invasive lumbar spine surgery. I'm going to focus on older patients because I think that's where this could be really beneficial. I was a consultant with DePuy Synthes Spine. The learning objectives are to understand the advantages of minimally invasive techniques, understand changing patient demographics, and understand the array of tools at our disposal. The minimally invasive spine techniques really aren't for every single patient, but I think as a modern day spine surgeon, we ought to try to employ these whenever possible. I Googled active old people when I was coming up with this talk. Because, right, 75 is the new 65. And the average life expectancy in the US has increased from 68 to 79 from 1960 to 2020. And the most rapid increase in spinal fusion rates has occurred in patients aged 65 or above. And really, just to put everything into perspective, lumbar fusions account for one of the top 3 areas of annual Medicare spending. And so, as would be expected, as the population ages, the number of older patients with degenerative spine disease requiring fusion surgery will continue to climb. So we really have to understand the risks and the benefits of minimally invasive spine surgery in the elderly. In 2015, the total cost for elective lumbar spinal fusions was estimated to be $24.3 billion. That's a huge increase from 2004. So we have to consider several things, the most important being bone quality, the presence of a deformity, and then the obvious comorbidities of diabetes, hypertension, heart disease. Suboptimal bone quality is a huge issue. Osteoporosis and low bone mass are a major public health threat. 80% of women will have osteoporosis eventually, and it poses a significant economic burden. So in spine surgery, this really affects our hardware. This is medical carpentry. So we're using screws, rods, disc implants to realign the spine, to stabilize the spine. And if your bone quality is suboptimal, it can lead to hardware loosening, so the pedicle screws loosen, subsidence, which is when the cage sinks into the bone, and vertebral fractures. Vertebral fractures are the #1 complication of osteoporosis, and about 25% of postmenopausal women will have a vertebral body fracture. Then there's this idea of worsening degenerative changes, where by fixing one thing, we upset something else. Sometimes when we immobilize part of the spine, it can accelerate degenerative changes at other levels. So it results in new problems in spite of successfully treating the original problem. So that could lead to a recurrent disc herniation, recurrent spinal stenosis, instability after doing a decompressive surgery, and more often than not, degenerative changes result in some sort of a deformity, be it a focal scoliosis that we call a fractional curve, or spondylolisthesis. And so our revision surgery is often aimed at stabilizing, at deformity correction, or to extend the hardware. So if someone's had a fusion at one level, you can't just decompress the next level up, because that will predispose them to needing more surgery. So MIS techniques, they've been shown to have comparable fusion rates and functional outcomes compared to open procedures with less associated morbidity, because for the most part, they're just variations of a traditional surgery. And they've been shown to result in lower blood loss, reduced tissue trauma, less post-op pain, which means that patients are mobilizing earlier, they're going home earlier, so the length of stay is lower, and patients are getting back to physical therapy sooner. So the advances, I say, are thanks to changes in approaches, to retractor development, to materials, especially in the cages and screws, and in navigation. So the approaches, you can approach a spine from the front, the side, the back. Traditionally, the spine has been approached from the back, and so in this picture on the right side, you see the PLIF and the TLIF. These are traditional posterior spine approaches that most surgeons are familiar with, and so by using specialized retractors, we're able to accomplish the same as we would with a traditional surgery, but using tissue-sparing approaches. And then we have our anterior and our lateral approaches, which are very helpful, especially in patients with osteoporosis or with complex deformities. For example, by going in from the front in an ALIF, particularly at at L5S1, we're building the foundation for the spine and for the spine surgery. When you build a house, you want to make sure your foundation is as strong as possible. And so the advantage of coming in from the front is that we're not limited by the anatomy of the nerves. Rather, we have this open field where we can place large cages that have greater surface area, and greater surface area results in more higher rates of fusion, better deformity correction. As Raul discussed earlier, fixing lordosis, fixing that natural curvature that the spine has, and it helps to reduce complications in older patients with suboptimal bone quality. Retractors have come a long way. Initially, with minimally invasive approaches, we used tubular retractors that limited us as far as our exposure. It's kind of like operating through the mouth of a beer bottle. And so with retractor technology, we came up with retractors that expand where we're able to work through smaller incisions, but then we get a wider exposure down at the bottom. And that allows us to have less tissue trauma. And it also allows us to use avascular planes. For example, in a lateral lumbar fusion, we take advantage of an avascular plane in the lateral retroperitoneal space where we can do surgery with minimal blood loss, but place nice big cages in there that sit on the hardest part of the bone called the apophyseal ring. And then in the lower left-hand corner, we see a minimally invasive anterior lumbar fusion. So we're using a small incision to get to the front part of the spine, and by having the patient on their side, it allows the peritoneum to essentially kind of roll off the spine and do the exposure for you. And in the upper left-hand corner, it's a combination of sort of a mini open procedure, kind of what we use for lumbar discectomy sometimes, along with percutaneous screws on the opposite side. And then the development of LED lights has really improved safety in surgery, because if you can't see what you're doing, you're guaranteed to hurt something. Materials are a big deal, because for the longest time, we harvested the patient's own bone, be it rib harvest and iliac crest harvest, and the patient would recover from surgery but still complain about the donor site for years on end. And then we transitioned to what's called structural allograft, which are bone plugs or bone implants made from the femur or fibula in cadavers. And the issue with that is oftentimes the body will reabsorb that, and then you're left with no cage in the disc space, and the patient's left hanging from the screws. So titanium cages have been developed in such a way that they have a similar modulus of elasticity. Essentially, it's just as hard as the bone, and by laser cutting them, essentially makes them a porous cage. It allows for bony ingrowth into the cage, which helps to improve fusion rates. When working from the back, we're very limited in the space that we have to place a cage, right? Because we're working between two nerve roots in what's called Camben's triangle. And so expandable cages improve the safety involved in placing a cage. When using a standard cage, you have to get the nerves out of the way, and then using a big hammer to put that through. And so if a nerve slides in, it can get injured. Whereas with an expandable cage, you can place it in while it's collapsed. Then once it's in the disc space, you can deploy it, and it's as if you place twice as big a cage. We use cadaver bone for bone graft, and now taking into account suboptimal bone quality, we have what are called fenestrated screws, which are screws with small holes around the edge. And once we put those screws in, we can cement the screws in place, which allows us to pull vertebra back and get better fixation. Navigation was a huge breakthrough, because when you're operating on older patients, there are going to be more arthritic changes, the joints are large, and before navigation, I remember at times spending 20 minutes trying to place one screw. And so with navigation, we use intraoperative CT scan. And there's an array that's placed on the patient, whether it's clamped on a spinous process or hammered into the posterior superior iliac spine, and that's a fixed point. You get a CT scan, and then our instruments are essentially connected to all that. So we're able to see exactly where the screw is. We're able to measure our screw size for the optimal screw use. And once we're done placing all the screws, we're able to get another CT scan so that we can leave the OR knowing that everything is in a good position. It allows us to use smaller incisions because we don't need to look at landmarks. And it helps to reduce the radiation exposure for everybody in the operating room. So the two main minimally invasive techniques for spine surgery are going to be the TLIF, or the transforaminal lumbar interbody fusion. This is a variation of a traditional open approach, which most surgeons are familiar with. It can be done with less than 50 cc's blood loss. I mean, most of the blood loss typically occurs once you're working in the epidural space, much like a lumbar discectomy. And the disadvantage is we have to use smaller implants because we're working through a smaller corridor. The disadvantage of a smaller implant with an older patient is that their bone is softer, and so we can't rely so much on that cage holding those vertebrae apart. The other kind of newer approach is a lateral lumbar interbody fusion that utilizes a lateral retroperitoneal approach. Typically 20 cc's of blood loss takes us about 2 hours. And in patients with osteoporosis, it's extremely helpful because the cages are as big as the disc space, so they sit on the hardest part of the bone called the apophyseal ring. So these implants are stiffer than the smaller TLIF cage, and they have probably about 3 times as much surface area to them. So by combining interbody cages with pedicle screw fixation, they essentially share the load. You have a cage in the front that supports the vertebra, and then you have the screws in the back that support that, but also allow us to pull the upper vertebra back to correct alignment. And this larger surface area implants are more resistant to loads, and they reduce subsidence, less risk of a vertebral body fracture, and a higher fusion rate. And it also allows us to restore alignment better, as well as lordosis. In the end, the outcomes are comparable at 2 years after surgery. Most surgeons are going to be more comfortable with one particular fusion technique, and with familiarity comes efficiency. Especially when you're operating older patients, you want to get in, you want to get out, and you want to do things safely. So most surgeons will choose a technique that allows for less blood loss, reduced tissue trauma, restoration of alignment, good spinal fixation, good nerve decompression, because what's the point of doing surgery if the patient's still going to have the same symptoms after surgery, and the least amount of time under anesthesia. So this here is a systematic review article looking at TLIF surgery in elderly patients, and it found that it was safe. It led to a high rate of fusion and a significant improvement in patient-reported outcomes. But as expected, older patients are going to get more complicated. And so the overall complication rate in an older patient over the age of 70 is about 25%. You have major complications, which is anything that would change the course of the patient's recovery, be it a postoperative hematoma, seroma, screw malposition, heart attack, PE. And then you have your minor complications, which don't, maybe it increases the length of stay, but doesn't really affect the overall outcome. So older patients in the hospital with muscle relaxants and Percocet and Dilaudid, they're going to have confusion. They're more likely to have a urinary tract infection. Men are more likely to have urinary retention related to prostate issues, anemia, a dural tear. They found that age does not affect the surgical complication rate. Surgery is surgery, whether the patient is 70 or 80. And they found that it's successful. It's a 90% fusion rate for single level at 2 years. And going back to what I discussed earlier about you fix one thing, you mess something up. It has a 6% adjacent segment disease. So by immobilizing one part of the spine, you wind up accelerating degenerative changes at other levels. And in this study, it came out to about 6% per year. And then this looks at the impact of age on approach-related complications with the lateral lumbar surgery, where we're using a lateral retroperitoneal approach. And so when we're doing this approach, you can injure the psoas, you can injure the lumbosacral plexus, you can injure the ureter. And if you're working at L4, L5, for example, the patient has a calcified iliac artery, you can have a vascular complication. And so they concluded that elderly patients do not appear to experience higher rates of approach-related complications compared with the non-elderly patients. So it's a safe procedure. I'll use this case here as an example. This is an 84-year-old lady who came in on a Friday morning with cauda-equina syndrome. She had 48 hours of urinary retention and subsequent overflow incontinence, perineal numbness, lower extremity pain, terrible sciatica, lower extremity weakness, and her MRI here shows severe canal stenosis at L4, L5 related to a grade 2 spondylolisthesis. So she was taken to the operating room Friday afternoon. This is her preoperative CT scan from 2013 and 2022, not a big difference. And we took everything we talked about and employed it in her. So we had a frail 84-year-old lady with a serious problem. And we needed to decompress her nerves to reverse the effects on her bladder and on her cauda-equina, essentially. And we had to stabilize the spine and we had to decompress the nerves. So here you see that we used a modified MIS approach. So on the patient's left side, you see these towers. Those are screws. And we have these towers so we can slide things down them. And then on the right side, we've exposed the right hemilamina, and in the surgery, we essentially removed all the bone on the right side of the spine, including the joint, in order to decompress the spinal canal and release that level so we can manipulate it. So in the bottom here, you see intraoperative x-rays. And what we've done is we've placed screws on the left side, and we use those screws with the rod to essentially hold that disc space open. And there's this paddle that's in the disc space that forces those vertebrae open. And then the middle picture shows that there's an open disc space. And you can see that we've already, just by restoring the height of the disc space, we've pulled that vertebra back. And then the third picture shows the cage going in. And she's 84, she's osteoporotic, she had very poor bone. So in order to manipulate the spine better and to make sure we had adequate fixation, we used fenestrated screws with cement augmentation just so we can get that purchase. It's like if you have an old cupboard and you can't get your screw to hold, you use that liquid nail, same thing. So MIS techniques, they allow us surgeons to tailor the surgical approaches to patient needs, anatomy, and medical comorbidities. They provide equivalent outcomes to traditional approaches. Even with these MIS options, the elderly patients are at an increased risk of complications. That's why I think that, if possible, we ought to use MIS techniques when the need arises. Thank you very much.
Thank you, Michael. So this is the last presentation of the session. I'm going to go fast, and then we'll have a break. All right, so these are my disclosures. Going to skip some of the back talk, but I came here in March of 2020 after spending 30 years at an academic institution on the West Coast. University of California, San Francisco, and 2 years in an academic institution in Vancouver, British Columbia, because I was from Canada originally. So that's my history of education. The important thing was that I got a lot of experience with administration of a department and a hospital while at UCSF. My chairman at the time had appointed me to some title called the Director of Patient Care Services. So I got to be on all the committees, block time, or committee, transfer center, bed utilization, et cetera, et cetera. So that was basically my on-the-job MBA. And if I would have come 10 to 15 years earlier, would the MBA have helped me? Maybe, a little bit. But I think the key was understanding hospital finance and the finance of what a neurosurgeon brought to the table, and you can extrapolate that to other physicians in practice. But it was a big transition for me going from being the busiest neurosurgeon at UCSF for 26 out of the 28 years to dropping down to 140 cases a year. And so you have to decide whether you're ready for that. One of the things I understood was that at the university system, the dean needs money, and the dean needs money to pay the non-interventional people to support their salary, because psychiatrist is necessary for an academic system, but they can't see enough patients to make a living wage in a busy, expensive city. So that's why the RVU system essentially came into place. And the RVU model helped pay the non-proceduralists. And if you look, for example, physicians in internal medicine, psychiatry, pediatrics, et cetera, and they don't get the same indirect benefit that a proceduralist would that generates income for the hospital. So on the other hand, there was a big difference between, in San Francisco, the collections for proceduralists and the RVU model. You can see what the swing was. It was 30%. So I was number 1 on the collection model, but I dropped to number 3 on the RVU model because spine surgeons keep making money for every level they operate on. The other thing was the understanding about directs versus indirects, and the indirects are all the income that you generate for the hospital based on patient stay, imaging, et cetera. One advantage for neuroscience is it's a very intensive equipment-related specialty, CT, MR, sometimes long hospital stays. Subarachnoid hemorrhage with ruptured aneurysm, average stays about 12, 14 days, depends. So those costs are significant for the insurance company. The hospital likes it, of course. But if you're in a system that develops a diagnostic-related group, they're only going to give you a certain amount of money for that diagnosis, and you have to do the best you can with it. So there was I think that was the education that I learned. This is what a neurosurgeon's worth to the hospital system on indirects. And then the contribution margin is the net of directs, which is collections, and then the indirects. And at least for our group, when we were 23 physicians, 8 neurosurgeons, the contribution margin was over $100 million on the hospital side. So we're valuable to the hospital. All physicians who admit patients to the hospital are valuable. Michael Gomez was just up here. Here's some of Michael's numbers. I can't read them from here, but you can see like over 1,408 months, total number of encounters. Surgical procedures are below that. Justin Spohr, same, very high number of encounters. He's our busiest surgeon by case volume. He does a lot of kyphoplasties for old people. And then if you drop down here, Felipe de los Ríos, he's the inpatient stroke neurologist. Over 2,200 encounters in 9 months of work. So very busy practice. And then if we look at the interventional service with Dr. DeBoos and Dr. Lamfonte, they're up to 1,400 procedures now. And on the physiatry, physical medicine, rehab, you can see a non-interventional physiatrist in 9 months saw 2,300 patients in the clinic. So that's a very busy practice. The busiest people in our whole practice are the pain anesthesiologists, and Moise Lustgarten is the total animal in our system with over 5,000 encounters in 9 months. We can't do that in neurosurgery, and his colleague is just behind him. This is what it looks like on the revenue side. I hope there's no hospital finance people here, but they really don't like the doctors to know this information. So that's one of the things that I had the advantage of knowing some of the numbers in the process. They couldn't pull the blinds over my eyes when it came to this. They would say, oh, your non-interventional physician hires lose money for us. Yeah, well, we make you another 120 million after that, so don't complain. We need these physicians to round out the neuroscience department, so I'm not listening to that. Advanced practice providers to help us. You can't have 10 physicians, all with advanced practice providers, hire another one and tell them they can't have one because the finance department says it costs too much money. No, that's not acceptable, and we need to fight for our docs in order to give them a fair shake and everybody gets treated equally. But you can see the revenue model as you hire more people, obviously. You make greater revenue, but you have additional expenses. But if you look at the contribution margins for a program beginning in roughly 2020 through to 2030, it's a big increase. Because I was raised in the academic system, I didn't want to do private practice. I could have done it, but I didn't want to run a business and try and do neurosurgery. So I defaulted to the academic model, enjoyed it my whole career, still do. And so Baptist had committed to a graduate medical education program, and you can see the list of specialties. Neurology started last July, neurosurgery starts in 28, physical medicine rehab will start in 29, but in total there'll be 23 residency programs by 2028, and by 2030 there'll be over 800 residents in place at the various hospitals in South Florida. And don't worry, the hospital, in addition, makes more money by having a residency program. They get the money from the government. The administration gets a little overwhelming. Yesterday morning, I helped my young colleague do a great case, 37-year-old woman with a very large 5-centimeter cerebellar convexity and tentorial meningioma, monitoring the pressure in the superior sagittal sinus, big aneurysm, clips on the sinus, take out the tumor, everything went fine. That's what I like. A day of doing email doesn't feel that productive to me. But the good thing about, I think, having, making decisions is very important for a leader to make decisions pretty quickly. They may not always be the correct decision, but I don't think you can cogitate too much on the pro and con. You have to have a vision for how things are probably going to work out. And with the help of my colleagues, as seen listed here, I think we've done a pretty good job. When I came, I was employee number 8. Now we have this many neurosurgeons and 2.5 interventionalists. Dr. Wicks is half open neurosurgery, half interventional. As I mentioned, they did 1,400 cases. When I came, we had one neurologist. He's sitting right there, Felipe de los Ríos. And we needed to ramp up quickly, and this is the number of neurologists we have now. The hiring plan is to hire 44 to cover a number of facilities in South Florida, mainly here. Physical medicine rehab, you can see the number of physicians. When I came, there were 3. And so we had a vision about what we thought we could accomplish. If you drop a pin at the University of Miami, the only academic center in the city of Miami, and draw a 50-mile radius, that's 6.8 million people. There's no way University of Miami can handle all those potential patients. You only need 175,000, 150,000 to provide enough work for neurosurgeons, so you can do the math. University of Miami would have to have 200 neurosurgeons working for them if they're going to meet the demand. And we know the same thing holds for neurology. If you call for a new patient appointment for MS, it's 10 months. Movement disorders, almost a year. So we're providing additional access for patients in this region. We also have a psychiatry program in combination with Florida International University. We hired a neuropsychologist. We're hiring a second. We have a neuropathologist finally. We had dermatopathologists trying to sign out our brain tumor specimens, sending them to MGH, University of Michigan, which would delay the diagnosis by 3 weeks. Now we don't have that problem. This is the basic clinical administrative structure, different divisions. We don't call them departments. The only designation of a department is at the university, so Department of Neuroscience, and then we have divisions similar to what are listed here. This is the operations group organization. Obviously, we all know about the fact that administrators' numbers keep going up more so than physicians, but we actually have the leanest group of all the institutes. We're the leanest and meanest ratio of doctors to administrators. And Rachel's been fantastic for our group, and she's in the upper right there. We do plan for continued growth. The initial pro forma went out to 2028, so that's still a few years away. I was able to recruit Dr. Bosch, who's going to be the president of our National Neurosurgery Organization in 2028. I actually helped train her when she was a resident, so it's nice to come full circle. And we look forward to other programs, as you can see listed here, developing these. And this is our achievement in physician recruit. The hardest position to recruit for is headache and dementia. They all want, a lot of money, and they don't want to work 5 days a week. And their numbers are few. So the number of fellowship-trained physicians, neurologists, and dementia and headache are not enough to meet the demand. You can see the number of encounters for the neuroscience group. So that's 116,000 patient visits in a year, which is a lot. And downstream, the indirects, we're exceeding our expectations in terms of imaging and MR and CT imaging, angiography, expensive tests, and they generate revenue for the hospital. And this is where we are. As I told you, headache and dementia is the problem for recruitment. Tomorrow, we have a young fellowship-trained memory and aging person coming. We have an endowed chair waiting for this person. If he signs, boom, $2 million. Endowed chair. So the principal will stay. Starting at 2 years, he'll get to use the interest income for travel, supporting his ability to give local, regional, national, international lectures, support clinical research, et cetera. And we will have one for a headache specialist as well. Obviously, the system's been very supportive and commitment to innovation. All these things cost money. Dr. Bosch needed a Rosa robot, $800,000, but we had foundation money, we were able to buy it. And she did her first case December the 4th, and she has another one scheduled next week. You heard Dr. Torres talk about the breakthrough with convection-enhanced delivery and adeno-associated virus vector 2 delivery of a gene product for Huntington's disease. Same thing is coming for Parkinson's disease, frontotemporal dementia, non-lesional medial temporal lobe epilepsy. And we needed this MR-directed ClearPoint system, which cost about $350,000. We got it because we had the money from philanthropy. And our next big expenditures down the road is a magnetoencephalography unit. There's only one provider in the entire country, which that's the definition of a monopoly. Those things used to cost $800,000, now they cost $3 million. So we have a little bit of other fundraising to do. This is the kind of graphic demonstration of plans for growth for neuroscience over 15 locations, which include both hospital and small clinic spaces, freestanding. We have put together, now this is where I used AI to provide me a framework for some proposals for donors. So I did one for FIU, I did one for dementias, did one for movement disorders, did one for brain tumor center, did one for neuro-ophthalmology. I put together the clinical framework in the background. Rachel does all the finance, tells the potential investor how much money it costs for each of these positions over X number of years. Here's the total. So this one, for example, is $13 million, okay, to pay for 5 years, hire 2 additional neuro-ophthalmologists, run a clinic, have support staff, et cetera. A lot of awards for high-quality care, particularly in stroke. Dr. De Los Ríos is the champion of awards at Baptist, so congratulations to him. And we cover everything from the lower Keys all the way up north to Boca Regional with our stroke program. One of the things that seems really weird to me as a neurosurgeon is that somebody figured out that if you put a vagal nerve stimulator, you can do it for epilepsy, but if you put one in, you can use it for improving the outcome of patients with rheumatoid arthritis. Some scientists figured out that if you run the vagal nerve stimulator for 5 minutes at midnight, it lowers the production of T cells and B cells from the spleen, which reduces inflammation in rheumatoid arthritis. So the neurosurgeons, we put in the vagal nerve stimulator. The device is now approved. The FDA approved it. The clinical trial was completed. It works, believe it or not. Also for stroke, at 6 months post-stroke, there are certain criteria. Dr. De Los Rios knows we implanted the first patient 3 months ago. We did the second one. It's coming up. And apparently, this promotes recovery beginning at 6 months post-stroke. And apparently, the first patients had a remarkable result in improvement, according to our rehab specialist from yesterday. So, it's a good thing for the patients. So if you have a stroke, it's not the end of the world. Neuroplasticity matters. We have other certifications that we're striving for in epilepsy, spine. We have a number of epileptologists. We got our epileptologist a seizure monitoring unit. Dr. Abosh is now putting stereo EEGs in. This all takes time and a lot of money. We spent a lot of money on neuropathology. It cost $3.4 million from the Nangurian Foundation to employ the neuropathologist and guarantee salary support for himself, his postdoc PhD physician, their lab support, consumables, non-consumables for 3 years. So, but we're delighted. One of my neurosurgeons said that was the best thing I did was to hire this neuropathologist in the last 5 years. So it's good. We don't get a frozen result said it's a tumor. No, we know that it's a tumor. That's why we're operating. But you've got to at least try and tell me what kind of tumor it is. We have a big data team behind us. It used to be called IT. Now it's called Technology and Development. They're helping us a lot with all the data that we're creating. And we have a robust research team. I think everybody has planned prospective clinical trials. There are 3 that are active. If you can imagine, we're working on a Department of Defense grant using 2 doses of whole brain radiation therapy for Alzheimer's patients. We have another grant injecting autologous fat-derived mesenchymal stem cells into the ventricle of patients with Alzheimer's disease. We have another trial that's funded, active. We've screened a lot of patients using low-intensity focused ultrasound for Alzheimer's. So I think we're busy, and we keep increasing our activity. Of course, that requires hiring more researchers who are non-revenue generating, right? So if you get indirects from the grant support for hiring those positions, for example, the whole brain radiation therapy trial will fund 64% of all the research personnel's salaries with that indirect money support. We can't do it without money. We've raised, until the end of November, since I came in March 2020, we've raised $118 million. Generous elderly people in South Florida and young people. Kenneth C. Griffin, founder of Citadel, gave us $50 million, which we're putting towards a building. But there have been other significant gifts which have helped us. For example, this donor has given us $9 million, allowing us to create fellowship programs in the different divisions, which is great because then we don't have to go through finance and justification. Well, we do, but we have the money. It should be just a rubber stamp. But it'll be great. We'll have all kinds of fellowship training. And when I came, we had no endowed chairs. I got the first one. During COVID, I wrote a 2-pager about why endowed chairs are important. Now we have 8. And these endowed chair monies help us with education, research, and new initiatives and new programs. We have 13 named lectureships supported by the foundation monies. Dr. Bosch was our first women in neuroscience lecturer. That's how she was able to see what we were up to down here, and that was one of the things I think that influenced her decision. She had 2 choices to make as to where to go, and she picked Miami. We're glad she did. So here's what the future holds for us. We wanted to build a building to put everybody together: neurology, neurosurgery, physical medicine, rehab, research, innovation. 1/3 of our ground floor space is going to be dedicated to radiosurgery equipment for treatment of brain disorders, not only brain tumors. We're going to start a neuromodulation program with Dr. Bosch, and this is what the building is going to look like. This is not what the original iteration was, but pretty close. It's going to be 5 floors, 158,000 square feet. Always takes longer to get going than you thought, but we should occupy it sometime in early 2029. Baptist and FIU signed a memorandum of understanding for education we're their clinical partner. They're the basic science unit. I got a tour one day of the campus, and I asked the guys, hey, what's that rectangle? What's that space? And they said, oh, it's a county fairground for parking. And I said, like, there's no cars there. They said, well, they only use it 3 weeks a year. So, of course, being a disruptor, I went to the dean and said, we need to build this. So a lot of background for it. I knew an architect in San Francisco whose head office is here. I went to him, pitched the deal, said, you know, there's one thing, you can't charge me anything for doing this. But he did a basic outline. But I think the opportunities are great. The downstream revenue from a biotech hub like this is 800,000 square feet of office and laboratory space, 1,500 parking spaces as opposed to 200. A central hub with a variety of different facilities, preserved Cuban fountain memorial, which nobody goes to, as far as I can tell, ever when I've been there. So we would make it a centerpiece of the development. And this is something that the university has to figure out. My job was to recommend it to them. I'm out. You guys find the developer, find the money, and go for it. But here's what the downstream effects are. Annual economic output, $6 billion per year potentially, okay, for the community. Lots of jobs, average salaries over 100,000. Very good. Lots of examples, Boston, San Diego, San Francisco. San Francisco was the highest investment research center in the world in 2023. Mission Bay, things that Aviva and I remember as a ship junkyard until the mayor donated the land and then offered it up at $1 a year rent until the building was built and occupied, then standard rates for occupying. So thank you very much for your attention, and I think we have a couple of questions from Zoom. There's a question from who, as a specialist, is qualified to perform an interventional procedure? Could this be an interventional cardiologist or not? And I'll let Guillermo handle that. Is he still here? Okay, so there's a number of interventional physicians. They're usually, for example, in neurointerventional radiology, you can be a radiologist, neurologist, or neurosurgeon. And we have Dr. DeBus is a radiologist by training, did a 2-year fellowship. Dr. Lamfonte is a neurologist, did a 2-year fellowship. Dr. Wicks is a neurosurgeon, did a 2-year fellowship. So they're certified, all of them equally, to perform neurointerventional procedures. Same kind of certification holds true for other specialties. Question 2 is, what are the risks, such as aggravation of clinical symptoms from endovascular delamination, so causing a dissection, I would assume. Philippe, can you help us with that? What the incidence of?
Oh, does this work? Okay, great, yeah. Perfect. Yes, I mean, that is something that we definitely see, and it's one of the reasons why it's so hard to do angioplasty and stenting for atherosclerosis, for example, on intracranial arteries, because you can make a dissection, and that can be, detrimental to the peri-procedural risk. Right now, we try to avoid doing as much angioplasty and stenting as we can. So it's really reserved for those patients that are failing medical management in the setting of, for example, atherosclerosis. But technology has to advance. I mean, there's great opportunities for new technology devices to minimize that. So hopefully in the future. But for now, really, it's minimizing the use of those devices intracranially.
Any questions from audience?
Dr. McDermott, if you can, for one. I know
Yeah.
Dr. Dabu's left, but I'd like to, we have many folks here that might call us for an air ambulance and a patient needs to be transferred. We've talked about how important it is to remove a thrombus, and the fastest the best. But maybe if the team can discuss also, we have a window and we'd like to work, and sometimes there is no interventionist available. And so how can we help? And then second is Dr. De Los Ríos, can you talk a little bit about what we did in Panama and how we help stroke?
Yeah, there's a lot of opportunities for organizing time-sensitive care for neurosciences, not just for stroke, but stroke is maybe one of the more clear examples. But there is a time window of up to 24 hours, and some patients can sustain that area of stroke to a small degree for even longer than that, and have an ample time for travel to receive that therapy. And there are several case reports and things that have already happened within the Caribbean, and a radius of by plane, if you could say, 5-6 hours even, you could probably coordinate endovascular thrombectomy at other sites where it is needed. So there are opportunities to coordinate that for stroke, and that is definitely an option even internationally. It takes a lot of pre-work, of course. It has to be protocolized. Otherwise, you'll never be able to get patients transport arranged and everything set up in time. But that's just one of the areas of stroke. That can definitely be done in many other areas where time-sensitive treatment is needed.
So if a patient is somewhere an hour away by fixed wing and they have a documented MCA occlusion, is there anything the docs there can do as a stopgap maneuver before they get here?
Yeah, thrombolytics is definitely an option. So thrombolytics can be initiated, I think, in most locations.
IV.
IV thrombolytics. And then there are some other measures that could be taken to try to preserve the penumbra, like maintaining good blood pressure, glucose, and things like that, avoiding hypotension. Organization of stroke care is key to that, so protocols and processes. And Dr. Ríos was talking about the efforts that we did in Panama when we started working with Clínica Hospital San Fernando a few years ago. There was no stroke certified center in Panama, but there were resources locally, and there were endovascular neurosurgeons. The care just needed to be coordinated. So we worked for about a couple of years, I would say, to organize the care and have it set up. And they've already gone their second or third certification internationally for stroke care. So now there's 2 certified stroke centers in Ciudad de Panama. And their experience has been great. They've been able to help lots of patients, locally with the resources that they had. It just needed some know-how as to how to organize that care. So it has been very impactful for the country, for the city. And it's a great story, and we can definitely help replicate that elsewhere.
Any questions from the audience? Dr. Bosch, for the non-surgeons in the audience, tell us, how long does it take to do a unilateral or a bilateral deep brain stimulator implant?
It depends on which technology workflow you're using. An intraoperative MRI case can be longer just because of the way the magnet, working in a magnetic field works. But bilateral can be 3 hours.
So not that long. Mike, what about a lateral approach for the technique that you showed there with posterior fusion or lateral fusion, that minimally invasive technique? How long does that take?
Typically about hour, 50 minutes or so. Yeah, about 20 cc's blood loss.
Yeah, and length of inpatient stay post-op?
We have patients walk in day of surgery, morning after they get a set of x-rays that we used to compare at 3 months, and then they're home day after surgery.
And do you have to use a brace for any period of time after the fusion?
So that's some surgeons use braces, others don't. There's not really any evidence to suggest that patients do better with braces, but I think some patients like to wear a brace kind of as like a psychological crutch. It kind of feels like they're safer with a brace on.
Yeah. And Aviva, how long after a DBS implant, unilateral or bilateral, does the patient stay in hospital before they go home?
Overnight, regular ward, home the following day. So you decrease complication rate by getting the patients out as quickly as possible, and there's no need to keep them in longer than that.
And how long does the battery last before you have to replace it?
Depends on what you're using. For a non-rechargeable, 3 to 5 years depending upon how you've programmed the battery, the voltage, et cetera. For a rechargeable, can be 10 to 15 years.
Wow. And for the non-rechargeable batteries, what's the procedure and how long does it take?
It's an outpatient, skin-to-skin, 12-minute, unzipping of the old incision. Cool. Nothing takes that small amount of time in a hospital environment, but it's my time is 12 minutes.
That sounds a lot better than some of my skull-based cases from the past.
Dr. McDermott,
Yeah.
you have a question in the
Yeah,
back?
please.
Hi, yeah. My question is regarding micro and nanoplastics and the gut-brain connection. Do you know if there's any research ongoing on either of them being a potential cause or treatment avenue for
Sorry, what was
movement disorders?
Yeah, what was the technique?
No. Microplastics.
Microplastics? I don't know. Aviva.
I mean, there's been a lot of research going on the accumulation of microplastics and
Oh, microplastics.
plastics. Yeah,
Oh,
plastics.
accumulation of plastics in our blood.
So it's really interesting and a topical question because there's increasing evidence that your microbiome of your gut can be the first sort of trigger entry for whatever is causing Parkinson's disease in the majority of sporadic cases. Every 10 years of my professional life, there's been some other theory about what is causing Parkinson's disease in the non-genetic cases. We thought it was, metals, heavy metals in our environment at one point. That's not proven to be true. It was fertilizers. That's proven not to be true, although these are interesting models in a research laboratory. So I think the best thing we can do is stay tuned and see where we get to with the notion of gut entry causing Parkinson's disease. It's an area, as I said, of active research.
Thank you.
Mm-hmm. Any other questions? Yes, sir.
Weight loss drugs, semaglutide, tirzepatide, what type of research do we have for cognitive decline outcomes with the use of tirzepatide or semaglutide and even Parkinson's disease? What are you reading? What do you have? I have some information on that I could share as well.
So I can take a step from the vascular side. We know these medications will lower your risk of stroke, right? So they have an FDA-approved indication for cardiovascular disease reduction if you have BMI greater than 27 and an additional cardiovascular risk factor. And cerebrovascular disease is the second leading cause of cognitive impairment and dementia. So there is going to be a downstream effect. The more stroke you can prevent, then the less dementia there's going to be. So that correlate, I think will be. I know there's studies ongoing for different other dementia categories besides vascular, but that will be one direct correlation for that. I'm not sure about in movement disorders if there's something specific there.
So there is an ongoing study looking at Lewy body dementia, specifically with Parkinson's disease. That's obviously not all of Parkinson's disease, but I'd be interested to hear what your data is.
So there's a Danish study going on where Parkinson's, cognitive decline, Alzheimer's is being studied. Every discipline is studying weight loss drugs with congestive heart failure, chronic kidney disease, neurovascular disease, cerebrovascular accidents, obesity, back surgery, and so forth and so on. So including sleep apnea. And so we know that obesity is the #1 cause of sleep apnea. And so just by reducing their weight and their BMI, they've shown a 40% decrease in sleep apnea, obstructive airway, and use of the mask, right? CPAP mask. So ongoing studies are going on right now with Parkinson's, which shows about 18 to 20% decrease or significant decline or improvement with Alzheimer's, cognitive decline, and even Parkinson's disease. I'll share that study with you, but it's not complete.
So one of the issues with the Parkinson's population, which I alluded to in my talk, is that they get terrible constipation. It's what happens when you pull dopaminergic innervation out of the gut. The problem with these compounds is that they create gastroparesis. They slow absorption of the Parkinson's medications, et cetera. So it's kind of a double-edged sword.
All right. So that ends our question and answer period. We're right on time. Coffee break. Come back here at 11:30 for Miami Cancer Institute series of presentations. Thank you very much.